सही। 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 सही।
गया तो।
ये तुम्हारे नाम पे कर दिया मैंने, लेकिन अभी शुरू नहीं हुआ शायद, देखो।
हाँ, थैंक यू। थैंक यू, थैंक यू। ये लो।
पराठा।
हाँ।
चलो बस बस।
देखो ले लो।
और नहीं, इतना नहीं दूंगी मैं, खाया ना मैंने इतना।
ये तो ले।
बहुत ज्यादा हो जाएगा।
अरे नहीं, ज्यादा नहीं।
सब्जी वब्जी तो कुछ है नहीं, तो कैसे चाय के साथ खाएंगे? ये
हाँ,
अभी शायद
चाय
शुरू
के
नहीं
साथ।
हुआ है। ये देखो।
तो मैं लेके आ रहा हूँ, फिर तुम खाओ।
हाँ ले लो।
हम्म।
ले आओ।
फिर चम्मच खा।
हाँ तो जाओ। जाना है? नहीं नहीं, स्वाद स्वाद नहीं खाएगा, ऐसे ही खा लो। इतना मत करो। बोलो अचार है तो दो। है, सब्जी है। मैंने सोचा सब्जी नहीं है। थैंक यू।
वेलकम।
अभी मैंने सोचा आप यहाँ पे आप ले लो इसको सब ले नहीं कुछ नहीं कुछ नहीं किया वो देख लेंगे तो तुम जाओ, ये खा लो। अरे पीछे 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 ठीक करो, पैंट अपना पैंट के अंदर चला गया, कोट कोट पैंट के अंदर चला गया। मैंने खा लिया है। मैंने खा लिया। हाँ वो सब्जी दे दी। चलो ठीक है।
किसको दूंगा?
नहीं सर, मुझे
कैंसिल
क्या
कर
कर रहे हो बता दो।
नहीं ये स्ट्रीम होगा ना सर जूम पे।
अच्छा ओके।
तो दिन मुझे क्या करना है अभी?
हम्म?
शेयर स्क्रीन करना है यहाँ पे जाके।
कर दो,
तो कुछ
शेयर स्क्रीन
मत कर
कर
मत कर मत कर। ठीक है
दो। आप एक बार कर दीजिए आपको।
चलो लगा लो
इसको बंद करो फिर।
हाँ, फिर बंद करें। ये जो
नहीं नहीं, अंकित सर है ना।
हो गया ना?
अच्छा, देखो
Great to be here. I think we'll all hear from all the nostalgia
Host
of the
disabled,
next
participant screen sharing.
hours over here. And without much ado, let's start and hear
फटाफट
from
करिए, फटाफट
the
करिए.
original first person of SGPCIMS, Dr. V.K. Kapoor. And we know that his name is synonymous with gallbladder. So we'll go around the world and the gallbladder. So let's go.
Zoom connected.
Zoom screen.
He has already said that his journey is very long. So there is no time cap for that journey. And we should all enjoy that journey with him.
Host disabled. Enable करो वो.
उनको you have the number? बीनल का? हाँ, उनको बोलो हमें host कर देंगे.
हमें होस्ट बना दीजिए, सॉरी इसको होस्ट बना दो।
मेरे को होस्ट बना दो बोल. क्योंकि ये जैसे
हाँ जी, नहीं डिसेबल्ड है वो स्क्रीन शेयरिंग।
You tell your ID, then only she will be able to do it. Is your which?
no, this one. Sorry,
Sorry,
जी.
so tell her that sorry.
This is a profile, sir.
उनको बोल
एक मिनट।
just
सुरेश
name.
मुखर्जी.
Yeah.
Audio
Now it's
source. iPhone ही से हो रहा है.
ठीक है, बढ़िया।
इसमें आ जाता है. ये शेयर स्क्रीन है. It's not working. You can use this app.
Good morning. For a change, I am a bit nervous. Because I think this is the first time that any one of us is addressing such a large gathering of the alumni of Surgical Gastroenterology Department of SGPGI. I hope and Kamaljeet will correct me if my pronunciation is wrong. The creme de la creme of surgical gastroenterology in India. First, I would like to thank Anu and the entire team for thinking about this kind of a program where all of us, as I think Pradeep was saying, that some of these must be like your grandchildren, and I think he's true, he's correct, because this is probably second or third generation now. So thank you, Anu. And we all should be grateful that the founder, SPK, as we used to call him, is here, not in his body, but as Robin. Robin, can you please? Robin is Dr. Kaushik's son, younger son? Yes. Who is now the chief of surgery at Government Medical College in Chandigarh. Thank you, Robin. So in the next about half an hour, I'll take you through the journey of the department of all of you, and particularly me, the world. I was thinking whether I should say on the gallbladder or with the gallbladder. But I decided with. Most of you know me, know my contact details, but I have still given my contact details for the students here who probably have not seen me here. So as most of you know, after I almost finished my term a year before that, in 2021, I moved to the Mahatma Gandhi Medical College and Hospital in Jaipur, which is a part of Mahatma Gandhi University of Medical Sciences and Technology. So in the department, I work as a professor, and one of your colleagues, Dr. Ajay Sharma, is my head of the department. And in the university, I am working as a pro vice chancellor, so I divide my time half and half. And I am supposed to look after, mentor, and promote academically the faculty and students of 8 colleges which are part of the university, including dental, nursing, occupational therapy, physiotherapy, health informatics, and others. So it's time for me to learn the ABCD of these disciplines also. My job here will finish in June 27 when I turn 70, and you are all my prospective employers. I'm looking for a position on 1st July 27. I don't operate now. All my cases are operated by Ajay. But I do OPD, I do ward rounds, I do teaching, I do, as I said, mentoring, and a lot of online teaching. Many of you have been part of that. So that is what I want to continue to pursue. And of course, writing. Writing. Now I'm trying to complete some of my books. Also, it's time for me to write my personal as well as professional wills. So personal property will obviously go to my kids, but the professional earnings will go to all of you. So I'm looking for volunteers who are willing to inherit my books, because I don't want my books to die with me. I want them to continue. So one book, Safe Cholecystectomy, which is a topic of great interest to both Sadiq and Librar here, has already been Vishal Gupta, who is the chief of GI surgery at AIIMS Bhopal. He has agreed to take it over. So he joined me as a co-author in the last edition, and now he's playing more role, and gradually I will transfer it to him. So there are several other books. If there are any volunteers, please do come forward. So my journey with the gallbladder cancer started way back in '88 when I was at AIMS. And there is a very interesting story. Most of the things I will tell as anecdotes and memories and reflections, very little scientific information. Dr. Blumgart was to visit the department, and a faculty meeting was held to decide what to present to him. And I was a very young, I and Dr. Arvind Kumar, who's now a robotic surgeon at Medanta, we were the youngest faculty members, and ad hoc. Ad hoc at that time was 3 months, extended every 3 months. So we were allowed to attend the meetings, but we were sitting at the back. And then various suggestions came, and I took courage, and that courage came because I used to be the Students' Union and Resident Doctors Association leader. Sadiq knows it well. So I raised my hand and said, sir, we should present something which he does not see. So two suggestions were given. One is abdominal tuberculosis, and other I said gallbladder cancer. I had an inkling at that time that GBC somehow is not there in the West. That little knowledge I had. So fortunately, my teachers were very gracious and they accepted the suggestion. And then as it happens, if you give a suggestion, then you have to do it also. So me and Dr. Arvind, we were given the responsibility of taking out the data of last 5 years, and under the guidance and supervision of Dr. Chattopadhyay, whom you all know. And this was presented, and then we published it also. And I think I'm correct, maybe Rajneesh and others who are connected with AIMS can testify. This, to my knowledge, is the only publication from AIMS which carries the names of all 4 unit heads in a single publication. There were 4 units there, but this is the only publication from AIMS which came out. Dr. L.K. Sharma, Dr. M.M. Kapoor, Dr. B.M.L. Kapoor, and Dr. I.K. Dhawan. So that is where my journey started. Then when I came to SCPGI, we used to do our OPD in the general hospital. This is January '89. Me and Dr. Rajan joined around the same time. He joined a few days before me. And there was, the main hospital building was not there. जो बीच में plaza है, वहाँ कीचड़ होती थी. I remember first time when I came, I soiled my shoes while crossing that area. And we used to do the OPD in the general hospital, the theater there in the general hospital. Sanjay would remember. And so after a few days, I realized that even in this hospital, where at that time the number of cases was too small, number of patients overall, because we were so far from city, there was no connectivity. Nobody knew SCPGI at that time, even in the city. I thought and realized that probably we are seeing more patients with gallbladder cancer here than I was seeing at AIMS, which was a big hospital. So Sandeep was there, and I told Sandeep, look, this is something which we should keep prospective record. So Sandeep was the first who started keeping data of all patients which we were seeing in the OPD with gallbladder cancer. And that is how the journey at SGPGI started. And of course, now the numbers have grown. This is when I left. We then stopped or lost track of patients which we were seeing in the OPD because there were so many. So we thought we'll keep a record of only admitted patients. And then we came down to only operated patients. And probably later, by the time Biju and others were there, it came to only resected patients. So it's a matter of pride that we probably have the world's largest single institution experiences with gallbladder cancer. SCPGI was a very, I'm sure it is still, very kind of different institution. We were the first institute in the country not to have MBBS, MD, MS. And at that time, our emoluments were same as AIMS and PGI Chandigarh, but our perks were even better than them. We were allowed one international conference in 3 years. So 91, when I had completed about 2 years, I went to Sweden and presented my first paper. I don't even remember whether it was oral or poster on palliative surgical procedures because most of the cases were palliation. And this is the only picture I have. That time we used to have a camera with roll. You have to buy the roll, put it in, take it out, develop it, then negatives will come, then you select which print to be made because every print costs. So this is the only picture, and I don't know who are the people sitting with me because I did not have any contacts then. This is the first publication, original article from the department on gallbladder cancer, and Dr. Sadiq was the first author. And in this, I think for the first time, again, probably we documented that at least in North India, gallbladder cancer is the commonest cause of malignant surgical obstructive jaundice, which is different from what is written in most of the textbooks. Now, of course, Indian textbooks do mention that, but this was the first paper. And as you would see in most of the publications, most publications have all the faculties' names because from day one, it was decided that we will work as a single unit, unlike some other premier institutions. I would not name them. Pradeep also is here, and he was the one who analyzed all the cases in terms of survival. And I still remember that I was very hesitant that cancer is such a prestigious journal. Would they even go through an article coming from India and on a disease which they may not be seeing? But I think he was insistent, and we did send it to cancer, and it got accepted in the first attempt only, and such a prestigious journal. And again, you would notice that in most, because Dr. Sadiq also at that time, if I remember correctly, was still a resident or had just become a young faculty member. In most of the publications, you would see that the first authors are students. Now, SGPGI had a academic exchange program with University of Nagoya. Even now, I'm sure some equipment in the theater and other places is where you can see that this is a gift from Japan under the JICA scheme. And we also had an exchange program. So these two people, Dr. Akiyama, who was an esophageal surgeon, and Dr. Nonami, who was an HPB surgeon, they came, and that's the dashing SPK standing there on the ये अपना वार्ड का काउंटर है and so with that connection, the Nagoya group was organizing the Japanese Surgical Society. So they were kind enough to invite a lot of us. I think I was there, Ravindra was there, Raj Prasad was there, Dr. Chatterjee was there, Dr. Kaushik, of course, was an invited speaker. We were all paper presenters with a travel grant. Dr. Bal, who was in endocrine surgery, was there. Ibrar Sab was there. I should have put that picture. वो train वाली हमारी picture है. So we all went to Japan, and that was, I think, for most of us, our first exposure to Japan. And of course, it was fascinating. And that opened the links for future contacts because Dr. Nonami then several years later invited me to be a guest lecturer at a digestive surgery meeting. This picture I remember because I was carrying a camera, but the role had finished, and I did not have the courage and economic strength to buy a role in Japan. And he realized that we have gone to see the castle, but I'm not taking any pictures. So he was intelligent enough, and so he went to a counter, and they used to have that disposable camera. So it is a camera which has one roll inside. You take pictures, and the whole camera is then given for processing. So he bought that camera, disposable camera for me, and then we took these pictures. Then we highlighted that early gallbladder cancer is an elusive disease because its clinical presentation is like gallstone disease. And here, as you can see, I am the first author because probably I became a little greedy that no, I should also have a first author publication on gallbladder cancer. And then we published segment 3 bypass. Of course, now I don't think for last 10 years or 15 years we might have done any, but at that time we used to do. And this publication is precious for me, and because next year when I went to UK on a Commonwealth Fellowship, I attended an HPB masterclass in Liverpool where Prof. Blumgart was there, and I requested him to put his autograph on this. So that's Prof. Blumgart's, and he was to play a major role in my career later, which I will mention. So 95 JSS grant was a courtesy grant. It was given by Nagoya Group to us because we had a collaboration with them. But next year, the conference was in Chiba. And this year, I think the grant was on merit because nobody knew us. And then I went to Chiba. And by that time, we had probably reviewed some of the articles written by Dr. Todoroki. He's no more now. He succumbed to cholangiocarcinoma. And I corresponded with him, and he said that, okay, if you are coming to Japan, we should meet. So he again, and his colleague, Dr. Miwa, who is a basic scientist. The last picture, of course, is a later visit when Dr. Narendra Krishnani from pathology and Dr. Suraksha Agrawal, who again was to play a major role in my career later. We went to Japan at their invitation to discuss some research collaboration. But the first two pictures are from the first visit. And in fact, a very rare thing in Japan that he invited me to his home also for a dinner. So this Mila was a research student of Indian origin with Dr. Todoroki's group. And then along with us, when she was there, when she came back to India, then she joined GB Pant Hospital with Dr. Anil Agrawal as a scientist. And these two publications came, which were the first publications on a basic scientific research aspect of gallbladder cancer. Many of these things, even today, I don't understand, although I'm a co-author. But she was the first research student truly to work on our biomaterial. And again, at that time, I took these DNA samples with me in my bag to Japan. Today, I wouldn't do that. See, carrying biomaterial without, of course, at that time, probably ICMR also was not that strict. I don't even remember whether I took institute's permission, but we did it. And today, obviously, I wouldn't do it. 97 took me to Commonwealth, UK for a one-year Commonwealth fellowship. During those days, again, an anecdote, Sandeep and his family was also there in the UK. And one week, I and Lily, we went to Italy, and Sandeep and Bhavna and their daughter Sona, they looked after our two sons, Manu and Molu, because we couldn't afford them to take to Italy. And we thought they would not be interested in Italy. बाद में उनको फिर compensate करने के लिए हमें एक 2-3 दिन के लिए उनको पेरिस ले जाना पड़ा डिज्नीलैंड घुमाने के लिए. But for 1 week they stayed with Sandeep and Bhavna. So I was with Prof. Benjamin, and half the week I used to spend in London School of Hygiene and Tropical Medicine with Prof. McMichael to learn epidemiology. I think that was very useful because I learned the ABCD of epidemiology, which is important. If you want to study a disease, you need to understand the epidemiology of the disease. I've given that address at the bottom for the young students and young faculty that you should try to aim for Commonwealth Fellowship. That time it used to be 1 year, but now I think Sanjay, when he went, Dr. Anu's husband, I think it was 6 months. And now probably they have reduced it to maybe even 3 months. So, but everybody should try to apply for one of these fellowships. And I can guide and help. So during my stay, then Prof. Benjamin funded me to go to Poland. And as I said, we took our children to France. So while they were going around Louvre and other places, I made a short day trip to IARC for making a presentation and for discussing some collaboration, although that did not materialize in future. Poland, again, East Europe is a kind of hub or central area for gallbladder cancer, but we don't see much about East Europe because their numbers are small and probably they don't publish in English journals. So during that time, Prof. Benjamin got an invitation from Dr. Henry Pitt for writing a chapter, and he was kind enough to ask me to write it. And the honorarium also, I think it was £200 he passed on to me. And during the same time, the UICC invited us to write a chapter on gallbladder and biliary tract cancer. Again, UICC offers a large number of fellowships. I think Anu went, Sadiq also went on UICC, Anand also went, and Rajneesh also, I think, went. Supriya went on some other fellowship. So there are several fellowships which are exclusively for young people. Even the Japan Surgical Society grants are for students and young doctors from developing and developed world. So there's no competition with the US, UK, Western Europe. You all must have a good abstract ready and apply for these grants. And then we wrote a editorial. I'm sure it got published because of Prof. Benjamin, but it was there. But probably it was a well-written leading article also. Why I say that? Because as a senior resident, I had written and authored with my senior, Dr. L.K. Sharma, a leading article on abdominal tuberculosis in BJS. So for both these, again, I received £100, which both the senior colleagues, they were gracious enough to tell me, ki nahi, nahi, aap rakh lo. And at that time, £100 for us was a big money. Then we established link with Dr. Ariksa Bala, who has done exemplary work on gallbladder cancer from Chile. Chile, South America is again like North India, a very high incidence area for gallbladder cancer. And then later he came to the department. You can see, I think that is Anand or is it Ashish at the corner? This one on the left side. And the next is a visitor from Sri Lanka who was with us as an observer. Dr. Ashok Senior is there, Anand is there, and Eric Savala. So he was with us for some time, and then we established some links with him. And then we felt that the staging of gallbladder cancer, which is decided by people sitting in the West who would see maybe a couple of cases in a year, is not accurate. And several times we have pointed out that there is need for modification of staging. Even today, we don't agree with the staging of gallbladder cancer, and we feel that it needs revision. It is not appropriate. So based on probably all this and my contact with what was called the International Gastrosurgical Club, later it has been renamed as International Association of Surgeons, Gastroenterologists and Oncologists, which is again going to play an important role later. I was introduced to this group by Dr. B. Krishna Rao, a surgeon from Chennai who used to do a lot of therapeutic endoscopy also at that time. And they invited us to bring out this special issue on gallbladder cancer. It was a special supplement where we invited people from all over the world, and they contributed articles and chapters. This is also an interesting story. I wrote this article, editorial for American Journal of Gastroenterology. It started with a case that this young lady comes with gallstone disease, cholecystectomy done, and incidentally gallbladder cancer is found. What will you do? So the article came back to me in a few days. That time it used to be by post. And they said, this is a case report. We will not publish it. I was angry. I wrote a stinker to the editor. I said, that means neither you nor your editorial board, and if at all peer review has been done, anybody has read the whole thing, because it is not a case report. A case has been given in the beginning as an example, and you haven't read it. They must have felt bad and they accepted it. So again, if you are right, be ready to speak, be ready to express your point of view, whether it is British, American, or anybody else. So American Journal of Gastroenterology for a surgical author is a prestigious publication, but I think it got published not on merit, but because they felt bad about it. Gajanan again looked into early. We had earlier said that early gallbladder cancer looks like gallstone disease, and in this article we highlighted the difference between 1A and 1B, and between 1 and 2, 3, and 4 stages as another group. Later on, Anu and then Bala, they analyzed the survival patterns of gallbladder cancer. And then this debate of gallstones versus gallbladder cancer. So with Prof. McMichael, I wrote an editorial, and then Anu helped me to write these. We had a debate also. And this was a very strange kind of a debate. The surgeon is saying, don't operate. And the physician is saying, operate on asymptomatic gallstones. Even today, when I debate with Usha Gupta is chief of gastroenterology at PGI Chandigarh, she says that all asymptomatic stones should be operated. I say that no, they should not be operated. So it's a strange kind of a situation. And then in 2008, when I went to the US, the first article is 2003, which was with Prof. Mike Michael, because as I told you, I studied epidemiology with him. So I read all the articles related to epidemiology gallbladder and realized that gallbladder cancer is common, not only us, the Asian Indians, but even in American Indians. So the title, that is why, was that gallbladder cancer is an Indian disease, whether it is Asian Indians or American Indians. And then 2008, I went to US on a 4-month Fulbright fellowship, where I visited, I think, more than 20 institutions, delivered lectures and grand rounds. I went from north to south, Canada border, Mexico border, East Coast, West Coast. Many of these lectures were very well funded. Some gave me even $1,000 as a lecture fee. So it was a financially also sumptuous visit, which helped in funding our son's education later. And then I attended this meeting of Native American Indian doctors and healthcare workers, and I met this lady and had a detailed discussion with her, not only on medical, but social, religious aspects. And surprisingly, so many of their cultural and social values, rituals resemble us. So maybe there is something common between us and them. And then we established links with Prof. Miyazaki. I'm sure those of you who haven't read must read his article on how to do a segment 4B and 5. That is the proper technique of doing 4B and 5. Many of us, when we do a larger wedge, we say we have done 4B and 5. That is not correct. So he's a leading authority on gallbladder cancer from Japan. And me and Lily, he invited her also. Her visit also was paid by them. And again, they came to our home. That is his son, who later became a neurosurgeon at our home here in front of the guest house. And then we went to Japan. And then we realized that this entity of thick walled gallbladder, we developed interest. Even earlier, the senior Dr. Ashok and I think Raghavendra Rao, the tall Raghavendra Rao, we had published articles on Xantho. And then Shrikant looked at consecutive thick walled gallbladders, where we highlighted the importance of suspicion, high suspicion of gallbladder cancer. And Shaleen wrote this editorial. And then again, much later, we described this technique of anticipatory. And once again, I became a little greedy and then, no, this is something new which we are describing. So I must be the first author. So that is why I put my name as first author. And I'm happy that some of you and many others who are not attached to SGPGI have now started doing anticipatory extended cholecystectomy for thick-walled gallbladder. But still, when I teach my resident, I say that don't mention it in the exam that Dr. Kapoor told this, because not many examiners may still be following it. Now, I have to mention one name, and that is this changed the entire thing. She introduced me to genetics, and she wrote the proposal, put my name as first, and sent it to DBT. And we got the grant. And then, of course, the journey started. I think, before this, Dr. Balraj Mittal and Dr. Gaur Chaudhary, they were doing some studies on gallbladder cancer, and Mahendra Kumar Singh was the student with them, PhD student, but they were again gracious enough to invite me to join, and he had some publications. But Padma was our true first student. And again, there is a story. She had some problems, and one day she came crying to our home. Lily would remember. And she wanted to leave. And then Lily talked to her, convinced her. And then she continued. She's now in UCSF. This is Mahendra. So he was actually Dr. Balraj's PhD student, Dr. Gaur Chaudhary and him, and he did some work. And then this was the time that we realized that lot of patients, when we are doing laparotomy, we find peritoneal dissemination, surface deposits on the liver, and we just close and come out. So it was thought that staging laparoscopy, I think around the same time, Dr. Anil Agrawal also was advocating this, but then we said that it must be done. And later on, NCCN also strongly recommended staging laparoscopy. Around this time, a new institution came up on the campus of SGPGI, nuclear magnetic resonance. And then we established links with them. And a lot of students, and all of them, which I have mentioned here, they are now postdoctoral or scientists in the US. They did a lot of work on analysis of bile, stone, blood, tissue. And the hypothesis was, my hunch was that it is the type of stone which probably increases the risk of gallbladder cancer. And gallbladder cancer with and without stones are two different diseases. So that was the hypothesis. And we had a lot of publications arising out of this collaboration. And then came a stage when probably our work was noticed, and many journals, including Journal of Surgical Oncology and Journal of HPV Surgery, invited me to write editorials and leading articles. So these were not submissions, these were invitations. And then, as I mentioned, I went to UK on Fulbright Fellowship. Again, young faculty who are working in institutions. This is a very prestigious fellowship, prestigious to the extent that when I was standing on the US immigration counter at the entry point, they asked me, "Why have you come here?" I said, "I am on a Fulbright Fellowship." So they said, like this. So it is a very prestigious fellowship, and all those who have good CV should think in terms of applying it. And Dr. John Hunter, I think Rajneesh went to OHSU later, and he was my host. And then he also wrote the editorial for the first edition of the Safe Cholecystectomy book. This was the visit when, again, I met Prof. Blumgart, and he took me to his chamber. He had retired by that time, the kind of job I'm looking for now. And he had this huge cupboard in his room full of all video cassettes. And he said, Dr. Kapoor, I am now working on this video book, and I come every day to the department, and I'm working on this. And he was then to write the foreword for my book on gallbladder cancer. And I also met Dr. Seymour Schwartz. All of us know him. And one Indian surgeon, I am not recollecting his name, transplant surgeon from PGI Chandigarh, he was there. And so Dr. Schwartz then wrote the foreword for my book, The Pearls in Clinical Surgery. And this is the time when I crisscrossed the country from north to south, east to west. Several institutions made a lot of money in terms of these grand round honoraria, and visited so many places in the US. This time I was alone. Lily was not with me. And then Ajay, who is now my head of the department, we looked into this entity that after cholecystectomy, if a patient comes with jaundice, it may not always be a trauma, biliary trauma and benign biliary stricture. It could be a missed gallbladder cancer also, which is also a very important observation that we noted, which is important in North India. And then Dr. Fong, Anu probably had gone to him before this. So by this time, he knew the department, and he invited us to write this chapter in his book, which Anu helped me to write. In fact, she wrote the whole thing. And then NCCN invited us to join in recommending the guidelines. And simultaneously, the work with Dr. Suraksha. And then, of course, sorry, this is pathology. So Neeraj now is in Raebareli, AIMS Raebareli. She worked with us and several other colleagues in pathology, Narendra Krishnani, Vinita Agrawal, and we did a lot of studies on immunohistochemistry. And then we highlighted that this north-south divide. The last sentence of this editorial is, which I think Anu thought, that nothing else can divide India, but gallbladder cancer does it into north and south. So this was the time that I wrote this small pocket book in an A to Z format on gallbladder cancer. And although it was not a very hi-fi book, very simple book, but Prof. Blumgard, because of my previous personal interaction with him. In fact, during that visit, I forgot, I met another doyen, Marshall Orloff, the portal hypertension man, whose two children, Susan Orloff and Mark Orloff. I think Pari and Charlene went to Mark Orloff, and they are both transplant surgeons. Susan died recently. So Dr. Mark Orloff, I think he was 85 at that time, but still he was coming to the department. So after my grand round presentation there, he took me to a local cafeteria for a breakfast. And so I've had the opportunity of having met all the doyens, including Blumgard, including Bismuth, including Marshall Orloff, including the liver surgeon from Japan, Dr. The name will come. So it's been my fortune, and this is all because of the department's experience and work on gallbladder cancer. So this was a prestigious invitation, the Chiba Japanese Surgical Society, and look at the title. The Japanese are inviting an Indian surgeon to give a critical review of the Japanese approach towards management of gallbladder cancer. And this is where I highlighted that aggressive approach is required not for advanced gallbladder cancer, but for early gallbladder cancer. And I still remember after my presentation, two young Japanese surgeons came and said to me, "Sir, this is what we feel is correct, because we have seen our senior colleagues doing these major heroic surgeries on these patients, but outcome is not very good." And this is the time when Biju had already become a consultant with us, and he initiated doing these major resections, and he published our experience with these extended resections. Kumudesh is sitting here. Kumudesh, can you stand? So Kumudesh, again, since बैठो, Kumudesh की कहानी भी बताना जरूरी है. Some of you may know who were here at that time. Kumudesh started with us as our patient. And he ran into problems, and he missed his studies because of that. So one day, this lady walks into my room, into my office with him and his mother, and says कि सर ये तो अब आपके पास छोड़ के जा रही हूँ. So he joined us on a drug. I think पहले तो शायद ऑनरी ही, पैसे भी नहीं हम इसको देते थे, ये हमारे साथ काम करता था. Then we got a एक फाइजर का ड्रग ट्रायल आया, तो इसको कुछ पैसे दिए. Then he joined as a PhD student, registered in another university, was working with Dr. Suraksha, completed his PhD. Then he spent 5 years in Israel, in University of Jerusalem, working with a leading neuroscientist. And now he has come back and he has joined Dr. Piyush Sani and Dr. Subhash Gupta in Max as a scientist. Thank you, Kumudesh, for coming. Yeah, John Cameron. So when I had gone to US, I went to Johns Hopkins, and again, Johns Hopkins at that time, John Cameron, Henry Pitt, Lilemo, they were all there. So it was the Mecca of biliary surgery. And they invited me to make this presentation on our experience of bile duct injuries. And this is a picture I took when we met in IHPBA in Switzerland. I and Lily, we were walking, and then suddenly I see this old man and old lady walking like this, and I recognized him, and I requested him, "Sir, can I have a picture with you?" And he was the editor of Advances in Surgery, and again, he invited us to write this chapter. So OHSU, I mentioned, Dr. John Hunter was my host, Rajneesh had gone there. And I think one of their faculty, Rajneesh, came to us also. Young faculty from OHSU came and visited the department, I think. Yeah. So we had links, and so Neeraj Kumari, the pathology faculty, she went to UICC, Dr. Christopher Corliss, on a UICC fellowship, and then she did this work with him. Again, a coincidence. I was attending, oh, sorry, This is JSGS. So JSGS and IASG entered into a kind of agreement that every year they would invite two of their speakers as guest faculty. So in this meeting, I and Dr. Benjamin Paraket, the colorectal surgeon, who is now gone to UK, we were nominated by IASG to represent India in the JSGS meeting, again at the invitation of the Japanese. And then I met Dr. Wakai, who again, Niigata University, and he was to play a role because he introduced me to his basic scientist, Dr. Suchiya, with whom then we did a lot of work. So these are all publications, Kumudesh, and then Ratnakar joined as, Ratnakar did his PhD in PGI, but then he joined me and Anu as a postdoctoral fellow, and a lot of publications with them. They have visited India almost every year. They now come to Jaipur also for the Jaipur Surgical Festival. And they invited Kumudesh to Japan. They have invited Ratnakar. And this year, one of my young scientist colleague in Jaipur probably will go to Japan at their invitation. Now, yeah, so this is another, is it okay?
जब तक आप सर
No, time.
उसी की बात कर रहे हैं
अच्छा।
आप इधर चल रहे हैं
Anu? Okay, I'll probably. So again, I read this article by one Dr. Kari Heminki. I didn't know him. He didn't know me. I wrote to him that I want to collaborate. I don't remember for what. And he said, no, I'm not working now, but I'll refer you to this colleague of mine in Heidelberg. Heidelberg, I had a connection because way back in 91, my first international fellowship was a DART, German Academic Exchange Fellowship. Heidelberg is one of the most beautiful cities in the world. And that time Lily didn't go, but later when Dr. Barmezo invited me, I made sure that Lily also goes, and it's a very beautiful place. So with him, we've done some work later, and he is a leading biostatistician and bioinformatic person who does this big data analysis, data which is generated by molecular studies. So this is the work which Ratnakar helped me to do with the doctor. It's still not published. We are waiting for publication. And then, of course, Indian Council of Medical Research invited Anu and me to be part of the guidelines along with several other people. Then this book came out again, MD Anderson, because at that time I had visited MD Anderson Hospital. I think Jayant went to MD Anderson. Yes, Jayant went to MD Anderson. And now who else is going? Kailash. Kailash? No, Kailash is going to St. Louis. Sorry. I think somebody else went to MD Anderson. And they were bringing out this book, so they invited me to write this chapter. This was a book on oncology in journal. And then surgical obstructive jaundice being a common presentation, we looked into this and had a few publications. Anu and I wrote this chapter. The chapter in the GI surgery book on jaundice. And then I highlighted the bad outcome of gallbladder cancer, that whether it is a bad disease per se. This again was a coincidence. I was attending the DDW, the SSAT meeting, and the president of IASG was to present the Indian perspective. But for some reason, he could not attend because of some permission issues. So just a day before, or maybe 2 days before in the evening, I received an email that would you be able to do it? And since the topic was gallbladder cancer, I immediately said yes. And I already had my previous presentations ready, and I made this presentation. Again, I received a handsome amount of honorarium for this. Now, again, a coincidence, there was a news item on the 9th page of Hindustan Times, which covers the foreign news, that this Indian origin scientist is working on gallbladder cancer at MD Anderson. So I got his email through the internet, wrote to him, he immediately responded. And then the collaboration continued. He's still in touch. He comes to India. We've started an NGO related to gallbladder cancer. And I think somebody went to him also as a postdoctoral fellow, and he's done exemplary. He's a GI medical oncologist. So anybody who wants to go into research aspect of oncology, he would be the right host. And then because of this confusion about various terminologies, we highlighted the standard terminology for gallbladder cancer. Gastroenterology is the most prestigious medical gastroenterology journal. I don't think we could ever had a publication, but again, courtesy Mahindra, we at least had a letter to editor in gastroenterology related to aflatoxins in gallbladder cancer. And then Usha invited me to join this review, which is very highly cited on gallbladder cancer. Usha, as I mentioned, is at PGI Chandigarh, a medical gastroenterologist. Then we collaborated with a university in Lucknow. Kumudesh again was part of this and did some publications on basic science. Pooja then joined us. Pooja is now with Dr. Javle, MD Anderson, as a postdoctoral fellow. And then Pankaj Gupta. Pankaj Gupta is a radiologist at PGI Chandigarh. He devised this GB rads like BIRADS, LIRADS, and PIRADS for prostate. And he invited me to join this group of authors. Nisar then joined me in highlighting how to manage polyps in a textbook. And then we were invited to join this international survey on gallbladder cancer. This is the most prestigious publication. Again, there is a story. Joan Roa is a pathologist in Chile, US trained. They submitted a proposal to Nature that we want to submit a review article on gallbladder cancer. So the editor wrote to them that gallbladder cancer is so common in South Asia, but you have no co-author from South Asia. So he then wrote to me that can we request as a second choice, but okay, that can you please join us? So that is how I joined. And this, to my mind, a surgeon having a publication in Nature is a dream come true. So this is the connection with the Heidelberg group, and they held a meeting. ULAT is a European Latin American consortium to look into biliary cancers, and they invited me to this meeting in Chile. And this is again the creme de la creme of gallbladder cancer in Chile. Eric Sabala, Roa, and a few others. And we are having this dinner in a typical Chilean restaurant. And once I moved to Jaipur, Piyush was already there. Piyush and Ajay were already there. And that was the main reason that I went to Jaipur after nearly finishing my term there. And then while we were there, Piyush did this survey on the practices on incidental gallbladder cancer. And taking a cue from that, we organized the third Jaipur, we have held 5 so far, third Jaipur Surgical Festival on a brainstorming session on incidental. Sadiq played a very important role there. And out of that, we already have 7 systematic reviews, and more are in the pipeline. Kailash has done 2 of them. Selva has done 1. Piyush has done 1. And several others are in pipeline. So this year also 6th Jaipur Surgical Festival, we are now planning and thinking of doing it as a consensus development conference for incidental gallbladder cancer. IASGO has been part of JSF from the very beginning. This year, Amasi have agreed to be a part, and I am inviting some surgical and oncology societies also to be part of that, so that it becomes a multi-society consensus on management of incidental gallbladder cancer. Ratnakar, as I mentioned, joined us as a postdoctoral fellow and did some work. All these publications are with Dr. Suchiya, the basic scientist from Japan, to whom I was introduced by Dr. Wakai. And now, since my innings is almost coming to a close, I thought it is time that I can afford to pass some sermons. So this is, I have crystallized that how today, if a patient with gallbladder cancer comes to me, I would manage it, and an appeal to all the general surgeons for proper management of early gallbladder cancer. This is a group in BITS Pilani. I think she read some of our articles on NMR and approached us. So now we have been working with her, analyzing the stones collected from various parts. Pradeep has been part of some of these studies. So I would end by saying that gallbladder has taken me to so many countries. US visits 20 plus, but of course, last few visits are for personal social reasons because our elder son is settled there. But Japan 10 plus, countries like Kazakhstan and Mauritius and Peru, some countries which till I visited them, I didn't even know where they are located. More than 150 visits all over the world. These are the institutions abroad which I have visited and delivered talks on gallbladder cancer. Some others were talks on bile duct injury and abdominal tuberculosis, various conferences abroad. This is the evidence which the SGPGI department has generated as far as gallbladder cancer is concerned. Last few publications are, of course, from the Mahatma Gandhi Hospital. And as I mentioned in between, not only academic, but even financial. I made a lot of money out of these fellowships, scholarships, because both I and Lily have very limited expenses. So we try to save every penny. And the honoraria, the grants for writing leading articles, chapters, and all. And I mentioned some names of people who went abroad on gallbladder cancer, and some of my colleagues from uh, Mahatma Gandhi Hospital have also gone. And uh, I didn't mention Korea in between, but Korea also, Dr. Han, who's a very skilled laparoscopic surgeon. Dr. Anil Agrawal introduced me to him, but now with the visit of Supriya and so many others, I think he has become a very good friend. And anybody wanting to go to Korea, in fact, they offer funded fellowships also for short time. And of course, it has brought laurels and name and prestige in various places like Google Scholar, Scholar GPS, and there are so many groups which now go through your publications and rank you on various scales. And this is when I was here at that time. Now, of course, many other surgeons from SGPGI, including Gaurav Agrawal and others, have joined the list. Uh, I should mention this. This should not have happened. I still feel bad about it. You don't find my name there. There are some reasons which I don't think need to go into detail. I felt that it is not me who was ignored. It was the department's contribution which was ignored in this guidelines. So my tips to my students and young colleagues here: develop an area of interest from the beginning. Don't think, do everything, surgically do everything, but develop an area of interest. My love started with abdominal tuberculosis when I was at AIMS, but it shifted to gallbladder cancer here. And later, when Sadiq and I joined together, it became bile duct injury. But develop an area of interest. Read about it. You should know everything about it. Document everything that you're doing, all cases that you are seeing, all interesting, unusual cases that you are seeing. Audit your data from time to time. Write. And writing, I'm sure Ibrar is going to tell you, there can be no better example than Ibrar, that why to write, how to write. Biju, of course, followed in his footsteps later. Collaborate not only within your institution, go out of your institution, in your city, outside the city, out of the state, out of your discipline like medicine. And now AI is the future. You all must read about AI, develop contacts with people who are working in AI and see how it can be used, establish network, and of course have good soft skills, both speaking and writing. These are some questions related to gallbladder cancer, which any one of you should pick up and work on that. I must admit that although I have said that I've gone around the world, but I haven't yet found the answer to the question which we asked in the beginning, that if a young lady today comes with asymptomatic stones, whether she should be operated or not. We still don't have the answer. You people can try to find out the answer to that question. So these are certain areas of research. You should pick them up. I can tell you there are funding agencies which are waiting for good proposals. They have funds. There are a lot of funds available with them, but they are waiting for good proposals. And this is the time when I can guide you, help you, and supervise you to do all these things. Feel free to contact me, to send your abstract, to send your article, to send your proposal, to send your idea. Call me anytime after 4 p.m. because now I work only 9 to 3, 3 to 4, I come home. After 4, I am available to anyone and everyone. Call me anytime to talk to me about anything, and I will be very happy to help you and guide you. So I must mention some names. As I mentioned, Sandeep started the journey, then Pradeep, Haribhakti. Sorry if I missed some names. Sonavane, Gajanan, Shaleen, DKV, Ram. Ram is now the Chief of Surgical Gastroenterology at SMS Jaipur. Manoj, and my research students, including Kumudesh, who is here. And finally, the essence of the entire journey came in the form of this monograph, which again has contributions from almost everybody who's who of gallbladder cancer, and the dedication is to 3 surgeons who have contributed to gallbladder cancer. This is my book. So if there are any exam going students here, I can't now provide you the soft copy, but surreptitiously, every time there is a class on a topic, you can ask me for a complimentary chapter. I can send it to you. This is an online tutorial which we do. I think some of you have attended it. Anand is my colleague at Mahatma Gandhi Hospital, but recently he has shifted to Santokba Durlabji with Dr. Rajesh Bhojwani, but he's still continuing to manage the affairs of GST. You are all most welcome to join. And the teachers here, please encourage and tell your students about this educational portal and the Jaipur Surgical Festival in December. Thank you. Sorry, but
You've been an inspiration, mentor to a lot of us. And thank you so much for sharing your journey. And we all find places in your journey, which is a privilege to be in that. Thank you very much. And I'm sure people will find inspiration from this and look at it to further your career and draw from this superb journey which he's had till now and it still continues to have. Thank you very much.
thank you.
Now I invite Sir T.D. Yadav, the professor of the Department of DJG. He has been alumni of our association. Most of us know about him, so I don't say something. Out of track, out of box, what he has said.
So namaskar, Suprabhat, Adab, and very good morning, Sat Sri Akal. So all of us, क्यों? इसमें सलमान खान क्या कर रहा है? So लखनऊ में आदाब नहीं बोलो तो पूरा नहीं होगा लखनऊ. So what a wonderful journey. मैं एक शेर बोलना चाहता हूँ सर के लिए कि अजीब शख्स है मंजिल पे भी नहीं रुकता. कहीं से उठाई हुई है, मेरी नहीं है. तो after so thanks Dr. Anu for inviting everybody and having such a wonderful get together, and you started with such a wonderful presentation. All of us have to learn from Dr. Kapoor, and we go on learning. So after seeing all these world of academics, I think there is something which we have to go into, look at our soul and see what can we do in a better way. All the publications and all these things are basically we are doing for the patient management. So what type of ethics we should follow? And there are so many things described in the literature, but I was thinking that our Indian contribution is ignored by somehow. Not by anybody, but all of our, most of our things, we take the lead from the Geneva ethical issues, and this has been revised time to time. So I thought we should go to little more back, what we have contributed when we were probably one of the leaders in the world. And there are many things may not be documented as required today, but it is mentioned. So that's why it is called as mythology. So I told Dr. Anu that what are the things we can learn as a doctor to contribute in a better way our knowledge, and can we learn from Indian mythology also? So that's why I'm taking back to you. And if you see the basic meaning of the Indian mythology, you know that this is a custom and character of the particular society, and custom, character, and morality. All this differs, to my mind, time to time and according to the place from where we are working, at what particular time you are working. And that's why in Hindi, I always say that Niti or Riti. Niti or Riti means the way you lead life, the type of character you follow, are जगह और समय के पाबंद हैं. जो आज सत्य है वो कल नहीं होगा, जो कल सत्य है वो 100% आज भी नहीं होगा. इसलिए judging somebody based on the place and the time is very important, rather than taking the some issues from certain part of the world and trying to take it, bring back to our this thing might not be 100% feasible. So going back to our Indian people who contributed in terms of ethics. So we know that there are two main gods of the medicine in Indian mythology. The number one is Dhanvantari, and second is Ashwini Kumars, and all their contributions have been mentioned in Sanskrit in Charak and Susutta Samhita. So Charak is, that he is a medicine god, medicine things, and Susutta was our surgeon, and whatever they decided, this is mentioned in their textbook. So what was about? I start with Dhanvantari. He is supposed to be the god of the Ayurveda, and if you see his avatar during Samudra Manthan, you see a picture of Lord Vishnu who's taking birth. If you see this picture of Lord Vishnu taking birth with a kalash, Amrit kalash in his hand, and this kalash had the nectar which was going to make the Devas immortal and in the fighting against the devils. So Asuron ke ladai mein, and this was made of the, so that was to be given to the people, and he described some very nice things about the pathology. So he appeared with, as I said, having medicinal herbs, and he symbolizes the divine origin of the healing, according to him. And he is revered in the Ayurveda as the god of the medicine. What was his purpose of the birth? The purpose was to alleviate human sufferings. And he embodies the core ethical practice. And he is worshipped in our literature for the good health, for the longevity, and for physician who removes the diseases. So that is how he is worshipped, and all these things are relevant today when you are practicing for the benefit of the patient. So there are certain key ethical principles Dhanvantari decides about a doctor, what he should do. So he should uphold the patient dignity, prioritize humanity welfare over the personal gains. Personal gains may be as a reward, or it can be maybe as a money also. So what he said, so I am working in Punjab, so I learned some Shabad also, and Guru Nanak said, Utsut Ninda, dono tyage. Utsut is a craving for the praise. So you are too much craving for the pain, or you are too much doing for the Ninda. Both are equally dangerous, and a person should try to avoid going around the bush, both. And these are the things which bring voices inside you. So that is very, very important. Practice truthfulness, satya, mercy, daya, and non-violence in the doctor for the patient interaction when you are doing interaction with the patient. And also maintain the secrecy, very, very important thing. This is all from Dhanvantari, please remember. So maintain the secrecy, maintain impartiality, regardless of caste, creed, status, and continuous self-improvement, Atma-Vishleshan. All these things maintain for a good doctor. These are the ethical principles Dhanvantari mentioned, which is mentioned in the Charak Samhita. And you can go into all these things word by word and see that these are the things which are very, very important for us and makes us different from other professionals, because we are directly related to the life and death of the person. And the basic aim of all these things is curing the sick and maintaining the health of a healthy person, like a prevention of the disease process. So this is all he mentioned. And if you see, Dhanvantari tradition is mentioned in our Charak Samhita. And Dhanvantari tradition is also called as Dhanvantari Sampradaya. Sampradaya is same, like a tradition. What he did in Dhanvantari Sampradaya, people do, they have influenced the surgical and healing ethics. Surgical and healing ethics in Susutta Samhita, and he also stressed empathy, Vaidruvati, and exemplary conduct, that is called as Sadhurta of the physician. So you have to maintain empathy and exemplary conduct. Both are mentioned in the Sanskrit, so I tried to make the English of both. And there are some rules which ensures trust, preventing harm, and providing holistic care. So we are seeing sometimes people say, ये मेरा एरिया नहीं है. In our country, this is very famous. ये तो गैस्ट्रो का है, ये मेडिकल गैस्ट्रो का है, ये तो एनेस्थीसिया वालों का काम है. So there should be a holistic approach. And again, I am repeating, nothing has been taken from the other literature. It is all from the same. So in Charak Samhita, in a nutshell, what has been said for a doctor? Na atma artha na api kam artha, na artha vatulam bhishak, Bhutadayam pradatmate chikisam kalpate hiye, meaning thereby, Atma Arth means for apne liye. The doctor who does his practice, medicine, not for money, but we can debate on that, for the gratification, not for gratification, not for any desire other than patient welfare, but for the and for the compassion toward all human beings, are the best quality of a physician. So this is what Charak Samhita describes much before anybody else has described about the ethical issues followed by a person. And that's why, as I said in the beginning, that I have chosen this to bring to knowledge that these are the things already described and in details. So this was the mention by the Dhanvantari, but the second group of the god of the healing, there are twin brothers which are called as Ashwani Kumars, and they are the son of the Surya. So son of the Surya, and they have the horse on their face because they travel with the very fast speed because of being the son of the Surya. I don't want to go into details of their birth, but both twin brothers they are the healers. So what is this thing? They are a spiritual force of renewal, speed, and divine vitality. These are the symbolic of the Swani Kumars, and they symbolize very quick action and a low threshold for the new venture. So timely care saves the life. I took the inference from that, much better than the perfect delayed care. So it is very, very important that in emergency, even what we say bailout laparotomy. So this is what is the message. The timely care is very important. And these Ashwani Kumars are the epitome of an ideal physician, emergency healing person, swift intervention, healing before irreversible damage occurs. And you have to make a balance between science and compassion. So if you are only finding going for science, I will tell later. And they have emphasized that healing without discrimination. This point is so important today you are seeing in our society. I take my only example. We came from very villages, rural India, and having known lesser English, eloquency of the language, absence, and what we suffered in the MBBS days. I'm happy that in surgical branches, at least your hard work is paid. But these are the things which I already mentioned, but we hardly follow. And that's why I thought I will describe me only. If you are not able to present a very nice English case presentation in your class in MBBS, you are not a good student. You will not be given the respect. That is what I thought. Most of our South India students who are coming from basic Tamil, coming from basic Telugu, they also feel the same way. One of my student in PGI said, "Mera sir kya galti hai? अगर मैं अच्छी इंग्लिश नहीं जानता तो मेरा क्या गलती?" One of the best senior registrar coming from basic Tamil Nadu, this thing. So this is very easy to say all these things, even for me to follow. But that's why I thought let's have this eye-opening that what are the things mentioned already and we are not following. So the Ashwani Kumars, since they were the sons of the Sur, their speed was like a light, and they taught spiritual youth, and they are symbol of the vitality. Very energetic people they are. So Charak code of conduct in a nutshell. What is this? This is again taken from the Charak Samhita, that if doctor should, while seeing his patient, he should be work friendly, he should have sympathy, he should have compassion towards his patient, treat according to one's capability without overstepping. So why I am saying without appropriate referral, this emphasis is same. No undue attachment after the recovery of the patient. All of us do with being the status of the people. Study thoroughly, including environment, patient factors before prescribing medicine. So I will give a very simple example. Suppose a gallbladder cancer has a metastatic disease, and he is born in my village, having 1 acre of land, and 10 people are surviving. Are you going for all the maps? You service one IS person, retired or mantri, or even us who are getting everything from the government of India, or if everything government is free, then you might achieve some 4 or 5 months, which is survival mentioned in the textbook for 1 month, lakhs of medicine. So this is very important that you should look around the patient and prescribe medications rather than blindly prescribing everything, everybody, and people sell their land. And 10 people become poor because of the one over ambitious treatment. That is very, very important. Practice without the arrogance and with humility and focus. That is what is mentioned. Prioritize non-violence, truthfulness, ethical conduct, which is initiation of the oath in the textbook, what he has mentioned, that should include vows against the harming, envy, and unrighteousness. So unfortunately, no teaching of ethics, morality, and social science have been there in our training program, in our MBBS or even MS. So that's why probably most of us are not aware of this thing. So Charak Samhita, again, I go and summarize that Charak says, thou shalt be free from the envy, not desert a patient. You should have a modest attire, no adultery, enter a patient's house with an attendant. Please remember, this has been mentioned that time. And now no divulge the secrets of the secret. In Sanskrit, he has mentioned the dvesh, desire, krodh, moh, kam, garv, ahankar, irisha, kathurta, and krudata, jhoot bolna, mithya, and alas. These are the ones who try to get rid of all these things. And these are the reasons for the infamy. So this is all mentioned in our textbooks of the Charak Samhita. Just after doing this, I thought we should also talk some ethics about mentor and mentee. And I start by saying that in our mythology, in all incarnations of the gods, they took the education from gurus. They will go to the ashram in the guru, where everybody will be equal. There is no separate place for the coming from the Rajasan and coming from the Prajasan. So everybody will have the same education. Everybody will have the same type of environment. They will eat the food, whatever is available at the Rishi's ashram. So that was the symbol that everybody, there is no tuition fee at all. So this was a symbol that the Siksha should be free of the cost. So also discussion. I took the name of Buddha because Buddha was the only saint in our history. Always encourage that don't follow me blindly. Just try to analyze whatever I say. And he said, Atadipo bhav. Atadipo bhav in that lipi is called as Khudi diya bano. So don't, that is what discussion he allowed. What is an ideal example of mentor and mentee? I don't think there is better example of Ramakrishna ji and Swami Vivekananda. Every time Swami Vivekananda will be fighting with Swami Ramakrishna about existence of the Devi Mata, what he used to call it. And at the end, he accepted, and he has written this. Fools go staggering to and fro like a blind led by a blind. Better example was shown by Dr. Kapoor right now. And they alone escape whose spiritual and nature has been touched and vivified by the Sadguru. That is what he said. And he also wrote somewhere that निर्वाण प्राप्त करना तो सरल है, लेकिन एक अच्छा आचार्य होना उससे भी ज्यादा कठिन है. That is what he mentioned. And this type of ethics people working in a education center should try to follow. He also wrote that all what I am today, he said, I was born in the streets of the Bengal, but whatever I am today is because of my guru who taught me everything. And that is what Swami Vivekananda said. And I will re-emphasize that Buddha also encouraged discussion. He said, Ata dipo bhav, khud diya bano. Adi Shankaracharya also mentioned something about a good mentor, good teacher. What he says, samagyan kriya siddham. It is the knowledge used in the practice. So if you are very knowledgeable, पूरा ज्ञान है लेकिन प्रैक्टिस में नहीं है. सारे आध्यात्म हम बात कर, लेकिन अगर हम प्रैक्टिस में नहीं तो that knowledge is of no use. That is very simple. So one of the very Sufi of the Arab later, very many years back, he said in the Prophet that knowledge without work is vain. Save it with your work, and work without love is also vain. Save it with your love. Meaning thereby, we have to work with the passion, with the dedication. Adi Shankaracharya also said, Ko Guru, who is the perceptor? He responded in his this thing, writing that one who has realized the truth and ever starving for the good of the disciple. So adhigata tattva शिष्य हिताय उदतः सततम. सदैव तैयार रहते हैं अपने शिष्य के लिए. That is what is we saw the many things here right now. So an ideal mentor, also this is from the Adi Shankaracharya, is who gets happiness when his disciple progresses higher and higher, even goes beyond him. So the Guru Dwarika was very happy when he used to see his Arjun hitting somebody or even defeating him at some places. Mahabharat, there are two main granth. Mahabharat, there is selecting when Bhishma was on the Satsaya, there is a chapter in Mahabharat, Punyatithi. And Yudhishthira was going to take the role of king. Then he was asked by Krishna to go and take some lessons from your this guru who is sitting there waiting for you. And then he told him, lack of anger for a good king. He is described as Kun, but very, very nice. You should have truthfulness, simplicity, lack of treachery, lack of pride, bashfulness, tolerance, and self-control, calmness of the mind, and should not take undesirable activities. So lower one, all these you should follow, and upper one, you should not be doing that. That is what even Mahabharata said. And very important thing which has been mentioned in our Grantha, that Kupatra ko daan dena paap hai. So you have to choose the part when you are giving something. So Duryodhan and Arjun and everybody got that Siksha from the same guru. Patra was not seen because of the compulsion, and he became such a one of worst person from the society, and Pandav became the better person for the society. So it is also important that professional excellence doesn't give any guarantee to the morality. Professionally excellent having no moral value, you are more dangerous for the society and than the less intelligent person. And as I said, the example of the Duryodhan. So appropriate mentee selection is the biggest responsibility as a mentor, that to whom you are teaching and giving this. So Kabir Das said that when you are a teacher is what? So Guru Kumhar Shish Kumbh hai, gahi gahi kaade phot. I belong to a village. I have seen how the things from the mitti jo banate hain for the colors ke liye, how it is prepared. So each and every small piece of rubbles are taken out by the Kumhar. And then after that he makes, and Bhitar har sahar de. Then making colors, he puts his hand behind that thumbs like that. So bahar mare chot. You are not going to hurt. Kaya kasht bhul nahi deve, nahi sansar chudave. This is what Kabir Das said. So as a good mentor, you are not going to kill somebody for the fault. But whatever you scold, people say, I was scolded. Ab to hamare bhi kehte, bhai, I was scolded. But what is your intention? Are you going to harm, or you are scolding for the better future? That is very, very important. And a real mentor takes all the evils out and shapes and enhances the professional career of his student. Also, this is a duty of mentor to prepare for the future challenges his students. Like many things people say, our teachers saw, we have not seen, but many things we see, our student will not see. But how they should be ready to face any challenge in the life. So Arjun asked Krishna, ये हमी को क्यों इतना कष्ट हो रहा है? जब से हम पैदा हुए हैं, कौरव हमारे पीछे पड़ा हुआ है. And now exile, the 1 year exile. He said, why I am facing this? Then Krishna responded, in the necessity of trials and tribulation to emerge in life, a fit persona to take the higher challenges, these difficulties come. Meaning thereby, then Krishna said, in exile, you go and take more shastra, because your enemies are Bhishma, your enemies are Karna. By default, your enemies are Duryodhan. Everybody is equally talented. Your guru is standing in front of you. So you take better shastra. Go to Krishna, go to Indra Bhagwan, and go to Shankarji. Take more shastra and come back so that you can face all these mighty people and give them back, because you have to fight for the benefit of the society. So mentor sends mentee. Dr. Kapoor tell everybody to go out and take a training for the better future. So just not for everything good, there are certain things bad also. So Guru Turacharya, though he was such a wonderful teacher that he liked Arjun more than his own son. And if you know, anybody knows, Brahmastra ka adha gyan diya tha. Only half he gave to his student, his son Ashwasthama, because of compulsion by his wife. But 100% of the Brahmastra was given to Arjun because of his dedication, and he knew that this person is not going to use for his personal benefit. So, but he also took the thumb of the Eklavya. So that was his bad part. We should learn from the good and bad that we should not be doing that. So this is very, very important. And so what is expected from the mentees? So choose your mentor, believe in him, define your path, dream for what you want, and don't give away in difficulty. That is what we learn from this thing. And this part is, I have taken that hard work, honesty, and sincerity is the key. Inquisitiveness is the ornament, I always say. Go on asking questions like Buddha said. And your 3 years are your fixed deposit. Our patients also need some respect. Basically, the person who is first time allows you to operate is the most neglected person in our country. So any BIP coming will not allow the registrar to operate. So we should always remember when we are dealing with our patient. So simati jal bharahi tarawa. So what is this? Kabir Das said that if a drop of the coming from the above and they are scared, is scattered in the whole universe, nothing is going to happen. So whatever you pick up, you make if the coil is the drops, then only a pond makes. So if you want to make a pond, ocean, then you have to pick up all the drops and coils rather than leave it here and there. So this is very, very important. And also we have to learn that sar ko gaye thotha de udai. Pick up the best things from your mythology. Pick up the best things from your seniors. Multiple problems you might have personality, but you take the best thing out of us and go ahead. That is what is the farthest thing. Few lines about organ donation we had in our literature, because this is also part of the ethics, and we also know that how Dadichi donated his body to use against the devils in the mentioned in this thing, and he just took his prana out and his bones were used. So organ donation was prevalent. And also the euthanasia, if you see the Jains, when they are not fruitful, when they think that they are dependent in the famine, when they are dependent on others, or there is shortage of the food, they go for the self-death. So these are the things also mentioned in our literature. The ethics of medical treatment, I thought something we should say, and withholding treatment when money is not there, passive refusal like AIDS and all, and euthanasia. These are the something which are in the medical history. There is no mention about the tuition fee. There is no mention about doctor treating the patient and coming out and asking for money. That's why I think most of the problems are occurring, because Shiksha is not free and medical is not free. The moment it is, I think we become more and more this thing ethical. There are ethics which is not known earlier. Ethical issues, fetal research, neural transplant, cloning, AIDS, bioterrorism, and abortion. These are the dynamic process, and nothing much has been mentioned in the literature about this thing. So what are we facing today? Just one or two lines, that legal problems because of the money involved. So somebody is paying. So if result is not according to him, then he goes to the court. So I heard lots of things we are seeing, doctors being hit in the every street because of this thing. So this code of Hammurabi, eye for eye and teeth for the teeth, is being followed just because of the lots of money involved in the medical management. And unfortunately, please don't mind it, there is a big nexus between doctor, industry, and chemist, and which is the root cause of the getting carried away, and the faith of the patient towards the doctor is fading because of this particular nexus. I must say that Indian doctors are still privileged. People still respect doctors in spite of all the problems we discuss. They earn well. They can play a decisive role in the society, while most of the Indians are poor and illiterate. So you can not only you can also help this in the betterment of the society. But many of us lack the expected compassion, humanness, and empathy because of the multiple reasons, because of the professional greed, because of the money which is we are required. Somebody is not very greedy, he's professionally greedy. He is overstepping, as we said in the beginning. Whatever is required, he's going beyond that. That is also very, very important. And root cause of patient dissatisfaction today is lack of communication with the patient. Even the illiterate person knows how we can make him understood. Anybody can make him understand. We should not be frightening. We should not hide anything when we are having document, especially complication, and we must encourage second opinion. So finally, ethics cannot be taught to anybody. Very simple. I can just try to give your opening, eye open, but cannot be taught. It has to come from your own self. You have to introspect, Atma-Vislesan, and see whether I am doing right thing, what is our code of conduct. Am I following, or I am just going by the different circumstances? And this is what is the center is ethics. And these are the components of this thing: patient, social, culture, media, disease process, and cost. So we have to choose very carefully and try to follow the path as much possible. This is my last slide, and I will just try to put in Hindi. Please remember, if somebody, I will try to translate that. Lakshman gets Shakti, Amogh. He becomes unconscious. Now, only one doctor available who lives in Lanka. Lanka is the city of enemy. दुश्मन के शहर में वैद्य है, फिर भी राम कह रहे हैं कि भाई एक वैद्य है जो हमारे भाई को बचा सकता है, उसको बुलाया जाए। तो लक्ष्मण, the Ram believes in the ethics of the Sushen Bed, who is sitting in the enemy kingdom. Still he sends Hanuman. Sushen Bed, who knows that this man who is now unconscious is going to fight with my lord, who is the king of the Sri Lanka, still he is ready to come and help him. Now remember, third ethics is Ravan, in which kingdom Sushen is there. This is very simple analogy. Sushen is there, and still he doesn't go and hang the Sushen. So I think nothing can be better taught than the Ramcharitmanas whole Ramayana about the medical ethics than this, that the type of level we maintain, that even enemy is believing that if I go to a doctor, he is not going to see whether I am enemy of him, whether I have done something wrong with him. He is going to follow only his ethics, which is the welfare of the patient. And this is the best example to my mind in our history. And that's why code of conduct, respect is so much that Raman doesn't do anything to Sushen Bed. Sushen Bed is not scared. He's not saying that let me ask my this thing. Today we have to, for everything, let us ask our director, HOD. So many hurdles are there, but only one ethics. He's not asking Hanuman, wait, let me talk to my Lord, whether he's going to punish me or not. He says, okay, I'm going. He comes and saves gives medicine, and Lakshmana wakes up. They are the brothers, kill the Ravan and he finishes his family. Still, there is no mention that Sukhenberg was hanged. So this is what I wanted to say. The finally gist of all is that patient is our first priority. If at all we can do in all the circumstances what is available today. I thank you for your kind attention. Thank you.
Thank you, Dr. Yadav, for doing such a hard work on this presentation and taking out so many things from our old books. So this is not a mythology, actually, they are true books. And the best example in our time, the Kumar in Khada, Dr. Sadiq was so nice of a Kumar that he made perfect Khadas for the society. So thank you for your presentation. If any of you have any question, then please happy to answer.
Yes.
Small comment. Actually, there is opposite also too. There were even rules for patient. There is one Sanskrit stanza. I cannot tell you that.
हिंदी में बता दीजिए.
When someone goes to a doctor or a king, he has to take something with him. He can't go barehanded. That was the meaning of that. So there is also opposite side. Even the patients, they had given ethics by the society that time. They don't go barehanded when you go to a king or a doctor. Can I have a mic or maybe I walk you there? This is not working. You're not working. Can I have a mic?
भाई आप
हमको बंद करना है।
जी तेरे से बड़ा माइक कौन?
Sir.
ये लो।
I mean, needless to say that it was a wonderful talk. The content was also wonderful. Is it relevant? In the last line, you sum it all. Ethics and morals cannot be taught. So where are we standing? Today, we got to live in Rome like Romans do. Yeah. What are the Romans doing today? How many people are ethical? How many people are moral? So you have to stay in a society where these people are there. They are in the majority. How am I supposed to exist when the larger chunk is following some principles which do not match mine?
ये शाम को डिस्कस हो।
Not only that.
बताइए
वीडियो नहीं आपने सुना नहीं, मैंने शुरू में कह दिया था, नीति और रीति समय और जगह के पाबंद है. अगर समय है तो, लेकिन there are certain things which still can be picked up. It's not that everything. So what I said that आपको देखना है, खुद ही अपने अंदर झांकना है. Undue things, so many things are being done. Please don't blame the society alone. Still we know what are the things being done. So अगर हम उसमें से कुछ भी ले सकते हैं तो that is what is the aim.
Exactly.
So my talk was not on ethics, Dr. KJ. I was to tell that there are certain things which are mentioned in our granthas, which can be. तो मैंने अभी पूछे यहाँ पे कितने नए लड़के जो कॉन्वेंट वॉन्वेंट पढ़े हैं, उनको पता है कि व्हाट दे चरक संहिता इज, व्हाट दे सेड, व्हाट इज सुश्रुत संहिता, व्हाट दे सेड. So that's why just to put a light on this was mentioned. So I'm not saying go and follow whatever I've been said. Certain things.
Thank you.
Okay, thank you.
Thank you very much. A big round of applause.
So that brings us to the end of the session 1. Now we'll be starting with session 2, lessons in musings. I would request the chairpersons to kindly come on the stage. Dr. V.K. Kapoor, sir, Pro Vice Chancellor, Mahatma Gandhi University, Jaipur. Dr. Rajneesh Singh, sir, Professor, Department of Surgical Gastroenterology, SGPGI, Lucknow. And Dr. Ranjit Vijayhari, Director, the Gastro Center, Trivandrum.
नाम बना देंगे एक बार।
क्या हुआ?
डिसेबल पार्टिसिपेंट्स
पार्टिसिपेंट्स देखो ना कितने हैं।
डन ना मैम,
एक मिनट।
शेयर करो एक बार। हाँ ठीक है मैम, हो गया जी। या वी आर शेयरिंग, अभी हम लाइव जा रहे हैं वापस। यस, ओके, थैंक यू मैम।
मैं कर देता हूँ। एक बार पूछो, दिख रहा है ना वो यूट्यूब में? हो गया ना? शुरू करें? So, a very good afternoon to all. We'll be starting the inaugural function. So, my regards and greetings to all the teachers, all my seniors, all the distinguished guests, and my dear friends. So, we have gathered all here, and I feel privileged to. Am I audible? Huh. We have gathered, and I feel privileged to welcome you all to the 25th SGB. Can we all settle down, please? Can we all settle down, please, for the inaugural function? बारिश, इसको बोल के आना, पीछ सबको बुला लो अंदर। We'll take a few minutes to settle down and then we'll start with the inaugural function, please. So I request you all to please settle down because we are already late with the sessions, so that we can start with the inaugural function and proceed for the photograph on time. बेटा एक हाथ से कहीं पे लिख दो सर। बेटा को तो अजीब सा लगेगा। कोई बात नहीं, कान से वहाँ पे वहाँ पे डायरेक्टर का नाम नोट फोल्ड डायरेक्टर करके कोई ये दो। नहीं नहीं सर, डायरेक्टर सर नहीं, सर का नाम नहीं, डायरेक्टर सर नहीं है, केवल एक बार अनु मैम से पूछ लो। शुरू करें सर। So we'll start with the inaugural function. I feel privileged to welcome you all to the 25th SG Week. Sir, can I request your attention, please? So this is what makes it special. This SG Week is because it is for the alumni and more special because it is by the alumni. And our alumni are so engrossed in themselves that so now they are settling down. So I think with the efforts of all, we'll make it a memorable event and which we will cherish the next few years when we'll again have a great gathering of alumni meet. Now in the next 2 days, we'll be celebrating our memories, our triumphs, our failures. We'll laugh, we'll cry, and most importantly, we'll strengthen our bonds. So to set the ball rolling, I request the presence of the following dignitaries on the dais. First of all, the acting director and dean for the day, Dr. Manoj, please, sir. The mentors of the surgical gastroenterology department, in fact, the pillars of the department, who have actually shouldered all the responsibilities and stood tall in all circumstances. First of all, the person who taught us aggression and style in surgery, Professor Rajan Saxena. The person who inculcated how to document your data, how to process your data, and then how to publish your data, Professor V.K. Kapoor, sir. And then, as we saw in the morning, the person of meticulousness, discipline, Professor Sadiq Sikora. And last but not the least, the person who has made this all happen, our beloved Professor and Head of the Surgical Gastroenterology, Dr. Anu. So we'll begin the proceedings with the ceremonial lamp lighting. And I request all the dignitaries to please step forward for the lamp lighting. Tamso Ma Jyotirgamaya. So from darkness to light, from ignorance to knowledge. This is what this symbolizes. And this is what we intend to do. Please put your hands together. Thank you, sir and ma'am. Now I request my team members to welcome the dignitaries with saplings, please. थोड़ा जल्दी कर लो मैडम, थोड़ा जल्दी कर लो, थोड़ा जल्दी कर लो, एक एक करके लेके जाओ, जाओ ना। हाँ एक साथ, प्लीज प्लीज गो ना, गो ना। Sister Grishma, Sister Rekha, they're all and her team are helping us with all the proceedings. So please, sapling to Professor Rajan Saxena, Professor Manoj Kumar, Professor V.K. Kapoor, Professor Sadik Sikora, and Professor Anu Bihari. Now I would request and invite Professor Anu to please present the welcome note.
Thank you very much, Rahul. Distinguished dignitaries on the dais and in the hall, respected teachers, dear alumni, my faculty colleagues, dear friends. It is with a sense of great happiness, privilege, and honor that on behalf of the Department of Surgical Gastroenterology, I welcome you all very warmly to the Silver Jubilee edition of the signature event, academic event of the department, the SG Week. I think some of you may not know, but a new concept in continuing medical education was started way back in 1991, the brainchild of the then head of the department, late Professor S.P. Kaushik. And in the early days, a small number of postgraduate students, young faculty, and practicing surgeons from all over India would be invited to spend 1 week in the department. And during the time, they would participate in the structured teaching program. They would attend the ward rounds. They would see moderated operative sessions during the day. And in the evening, they would interact with have lectures with the invited faculty. And the hallmarks of the SG Week over the years have been the excellent course content, the amount of time which was given for interaction with the faculty, discussion, and the fact that the invited faculty were stalwarts, both national and international stalwarts in surgical gastroenterology. And as you can see, over the years, a wide array of topics have been covered. See, this was way back in 1991, the first SG Week. And I do not know whether Dr. Gaurav Agarwal is here. He's now the head of the Department of Endocrine Surgery. And he told me that he attended this, and I can actually recognize him. Let me just, it's okay. So, this surgical gastroenterology week, the Silver Jubilee, actually it seemed very natural and most appropriate to celebrate it with our alumni, because they are the very people who have built the foundation of what this department stands for and has grown into. And since we had this wonderful opportunity of having so many of our alumni here with us, we wanted to have a course content which was dedicated to topics which are very important but seldom discussed in the usual conferences. We chose to call them parasurgical skills. We wanted the senior alumni to share their vast experience with the younger ones. We also wanted the younger ones to showcase their experience. And therefore, we tailored the topics towards this aim. Now, it's a matter of great pride for the department that our alumni are in positions of leadership in both public and private, not only within India, but also outside. And what is a matter of even greater pride for us is that not only, okay, that whatever they learned from here, they have built upon it and taken it to even greater heights. And it's a great honor and privilege for us that so many of you have taken out time from your busy schedules to be with us as a part of this celebration. And in fact, as a matter of fact, this event has been co-created
with your enthusiastic participation, encouragement, and it is a testimony to the deep bonds of affection that you share with this department. Now, on this celebratory day, we not only want to feel proud of our past, but we also want to reaffirm our commitment to the ideals and values which this department has cherished for years. And I feel that competition is good, but collaboration is better. And I cannot think of a better group of people than the alumni group, where we can begin to talk about developing an ecosystem of collaboration. And my hope is that this event is only the first one in a continuing and long partnership of the alumni with the department, where what I like to consider as SG circles, where we connect, mutually inspire, collaborate, learn, educate, and do research together. And actually, I can think of a number of ways in which this can be done together. And I hope that many of you will keep on adding to it. It can be in the form of teaching. And I think I've been talking to many of our alumni. It's okay. It can be in the form of teaching. We can have the senior faculty as visiting professors. We can have short workshops by our younger alumni. We can have travel grants for a young surgical gastroenterologist. Most importantly, we can do collaborative research. Now that we have so many of our alumni in all the leading institutions of the country, I see no reason why on problems, especially those which are local to our place, to India, we cannot collaborate. And we can also have an association create a corpus for funding of alumni activities and plan and execute annual activities so that this becomes an ongoing and continuous collaboration of alumni with the department. A very important part of this inaugural function is to acknowledge the contribution of and show our appreciation for the founding members of the department, our respected teachers, who laid a solid foundation for the department to grow and mature to the present stature. Dr. S.P. Kaushik, along with Dr. Rajan Saxena, Dr. Vinay Kapoor, Dr. Sadiq Sikora, right from the very beginning, they aspired for the department to be one of the very best of its kind in terms of patient care, teaching, research, and training. And they laid a very firm foundation for this by establishing and maintaining systems that included meticulous record keeping. I do not know whether many of you can recognize, this is the department's first OT register. You can see Dr. Kapoor's handwriting. Some of the pages have Dr. Rajan's handwriting, and I don't let anybody touch this register because now it is in a state that the pages are falling apart. And when the NAT team came for accreditation, they were asking for so many documents. We had to bring out all kinds of documents. I showed all the documents, but at the end I said, I've shown you what you wanted me to show you. Now you have to see what I want to show you. And I showed them this register and I said, for me, this register is my legacy because these were the seniors who wanted the department to be a certain way. And that is why it is important for me. So they insisted on this meticulous record keeping, a structured teaching program, rigorous day-to-day and a periodic assessment of resident training, insisted that there be regular participation in state, national, and international conferences, and a very firm emphasis on publishing the departmental experience. And we are forever grateful to you for sowing the seeds of a relentless pursuit of academic excellence. And that is what you see in your alumni even now, who are carrying the surgical gastroenterology SGPGI flag high. Thank you very much. Professor S.P. Kaushik is not with us in form today, but I think he would have been extremely proud and very happy to see us together like this. And I'm really grateful to Dr. Robin Kaushik, who very graciously accepted our invitation to join us in this function and gave us an opportunity to honor Professor Kaushik's memory and contribution. We also want to acknowledge the contribution of Dr. Soma Kaushik, Mrs. Lily Kapoor, Dr. Ruchi Saxena, and Dr. Rehana Sikora, whose steadfast and unwavering support in health and in sickness and in all phases and stages of life, and in taking care of everything else, which allowed their spouses to the total freedom to follow and pursue their dreams and aspirations. I have had the opportunity to witness this silent support and did not want to lose the opportunity of acknowledging and expressing our appreciation. For the program, we have tried to weave a tapestry with threads of serious deliberation as well as fun and joy. And I hope that we'll have a happy and fruitful 2 days of learning, playfulness, and camaraderie. Thank you very much for making this day possible. I now request Rahul to continue.
Thank you, ma'am, for this overwhelming speech. I request Dr. Manoj to please say a few words of encouragement for us.
Thank you, Professor Anubihari. So today I'm representing Dean and Director of the Institute. So I had privilege here to connect with you. First of all, it's a great honor for me to share the dais with our respected teachers. All that say, I cannot believe I'm sharing dais with Professor Rajan Saxena, Professor V.K. Kapoor, Professor Dr. Sikora. They all have taught me during my residency time when I was doing residency in pathology and I was. So it's a great honor for me. So first of all, I congratulate department for holding this SG week. And as you all know, this department was established long back in 89-90 with Professor S.P. Kaushik with very high standard. And then Dr. Rajan Saxena, Professor V.K. Kapoor, Dr. Sikora, in my memory, I was resident at that time. So they all took this department to greater heights. And this department was in forefront leader in the country. Everyone is looking here for all laparoscopic surgeries, all complicated surgeries. So that's why I remember, because all complicated specimens we used to get in the department done by. And there was so much enthusiasm after doing surgery, they come to department to immediately for the reports. I remember those days. So department was established very high standard, and I welcome all the distinguished alumni here, distinguished faculty who has come to cherish the moment as they should. They have spent time here because, as you know, institute is growing. Time again, it has grown a lot. So, Dr. Kapoor, I just thank Dr. Kapoor, Dr. Rajan Saxena, Dr. Sikora, Dr. Rajneesh Singh, all in the department faculty, I congratulate everyone to hold this conference, and I think this conference will go. This will take further, and there are bigger challenges that AI is coming, so they have not to stop here because bigger challenges are coming, and they will. I think they will be leader in the artificial intelligence implementing in the surgical gastroenterology, and institute is just going the quaternary phase. That is not here, otherwise we would have explained in more detail our quaternary care project of the institute. So this department will also take lead in that direction also, and it will be guiding force for the whole country in developing human resource and teaching and research in this area. So I congratulate department for holding this CM. Thank you.
Thank you, sir. And our executive registrar, Colonel Varun Vajpayee, has just joined us. So I'll request my team member to please present a sapling to our ER, sir, Colonel Vajpayee. And now it's the time to celebrate our legacy and pay a tribute to our teachers. So I request Professor Love Kakkar and Professor Anubihari to present a plaque and shawl to Professor Robin in the memory of Professor S.P. Kaushik, the pillar stone of surgical gastroenterology of SGPGI. His name goes synonymous with this department. Please, S.P. Kaushik. Yes. लिली मैम को लेके जाएगा ऊपर ही। आप लिली मैम को ऊपर लेके जाएंगे वहीं पे करेगा। फोटो खराब हो रहा है।
differentiation features we want that scope
Good afternoon, everyone. At the outset, I would like to thank Anu ma'am and the organizing team of SGPJ department for making this wonderful meeting happen. It's both intellectually and emotionally a lot of homecoming for us. It's also a proud moment for me to share the podium where stalwarts have been talking since morning. My talk today is to talk about the journey of surgical gastroenterology as a specialty, which started as an open process and then to laparoscopy and robotic, and throw light on what the future holds for us. The context for this has been set aptly by the previous two speakers, Dr. Haribhakti sir and Dr. Pradeep sir, who have given a sneak preview as to what the future holds for us. But I would make a disclaimer, this talk is not about why robotic is better than laparoscopy or where open surgery scores. This audience does not need a lecture on these things. As we know, open surgery historically defined GA practice. All of us, at least till this generation, have started their practice doing a lot of open surgery. And that definitely gave us a lot of learning on anatomical mastery. It helped us do radical oncological resections. It also laid the foundation for many procedures. All the complex procedures we do now in minimal access started as open procedures. We had very strong foundations because of that. But then laparoscopy obviously changed the entire paradigm. We moved from a strength-based procedure to a skill-based operation. And now minimal access and laparoscopy is the dominant technology. But as we all know, laparoscopy has its own limitations, and the robot came in to address these. 3D magnified vision, registered instruments, tremor filtration, all these definitely improved the way we started doing minimal access surgery with the robot. We have to understand that robotic is not automation, it is surgical augmentation. You are still in charge of the entire surgery. But now, if you see, very rapidly, surgical gastroenterology is undergoing a lot of paradigm shifts. We are on the throes of a technological revolution. Like the last two lectures, you saw what all technology is coming in very rapidly at us. On the other hand, there is a lot of philosophical shift on how we treat diseases. There is also a biological transition as to how we understand the disease process, and thereby our treatments might undergo a radical shift in the way we manage diseases. So it used to be an exposure-driven skill earlier. Now we want precision. Our earlier focus was anatomy. Now we are already mastered. We are focusing on how much function can you preserve at the end of your mutilating surgery. Previously, our metric of success was survival. How long could a patient live after your surgery? Now we are actually focusing on the quality of life, what you can provide after you have done your surgery. So these are actually quite significant paradigm shifts in the way we practice surgical gastroenterology. So many of you might remember this scene. This is a scene from the movie Matrix where you can see the Agent Smith. He pulls out a rigid small capsule and suddenly it breaks into a creature, and that enters the navel of the hero. At that point, it looked like a very fantastic science fiction imagination. But and you can see that insect going into it. It's actually a tracker which is there inside his body, and then he will be tracked wherever he went. But if you see, this is actually reality. This is reality now. The robot which you saw there is called a continuum robot, meaning the entire rigid structure you saw is made of multiple small segments which can actually bend and move individually. And each part of the segment can be controlled independently. If you can see, this is actually a model of the continuum robot. So it has got multiple segments. Each segment can stretch, contract, it can move. So it has got infinite number of movements all around. And you can control each of these parts from outside precisely. This is exactly like an elephant's trunk. So this is not science fiction anymore. And this is definitely useful to revolutionize many procedures. Like if you see a transnasal pituitary surgery, which used to be very difficult with rigid instruments, with a continuum robot, you can actually navigate very easily through the nasal turbines and reach your place of interest and do a pituitary surgery. This has already started finding experimental uses in narrow cavity operations, in colonoscopic procedures, where you send a continuum robot, it starts searching out, you can guide the entire robot, it has got infinite degrees of freedom, and it goes and does the job. Humanoid robotic surgery, the next thing which is coming up. Humanoids are no longer science fiction again. They are definitely being tested in many aspects. This is actually a real life humanoid doing various procedures and proving its efficacy in that it can even do a Leopold's maneuver to check the position of the fetus accurately. And this humanoid is actually, you are not there with autonomous surgery yet. You cannot allow a humanoid to do a full surgery, but there is definitely a new technology where the surgeon sits somewhere on a robot, the humanoid is elsewhere, the surgeon operates the robot, the input of the robot goes to the humanoid, and the humanoid starts doing a laparoscopic surgery with the articulating instrument on the patient. You might wonder, why not just do a robotic telesurgery? This has got an advantage because you need not transfer the robot or have two robots at two places. You need not invest on two robotic sets of instruments because the humanoid only uses laparoscopic instruments. The humanoid flies to various places just like a human would do, and all the hospital needs to stock is a set of articulated laparoscopic instruments. And the surgeon completely controls it. There is an added advantage that the humanoid will cut out all your tremors. So you get the best of both worlds where you actually cut down the cost and increase the efficiency and actually do a robotic surgery using a humanoid. So this is again in the experimental process, it is no longer fiction. Miniature robots are the next thing. They are like, if you see this, these are the standard robotic arms, but just that instead of having three huge arms, you mount everything on a single sleeve. So you put an port into the umbilicus, you put a sleeve inside, and out comes three arms. One has a camera, and there are two articulating wrists. You might wonder, why is it different from a robot? Because here you don't have to worry where your ports are placed. Anywhere in the abdomen you put the port, you can go and operate anywhere else. There is no, like in a robotic surgery, you have to really plan your ports out because you have three different arms coming in from three different directions. Again, the precision is very high. Your vision is directly at the wrist. So you can actually see a single sleeve coming in and doing the operation. And this is being developed by a company called Vicarious Robots. And this robot is called a legacy robot. And this is definitely going to revolutionize, cut costs, and every operation will be done through a single incision without the hassle of planning out the ports. Autonomous and AI-assisted surgery, definitely these are on the pinnacle of technical excellence where the robot goes and does the entire surgery. Even though we are not there yet, there are a lot of single steps of operation which can be automated. You do the entire operation, but there are certain parts of an operation where your technique actually decides if the patient is going to live or not, like an anastomosis. There you make it autonomous where a robot does a laser sealing in a very precise way. That part is left to the robot completely. It is very akin to your flight. The pilot flies the flight when you can also always have a autopilot flying it or landing it where you are absolutely safe. So autonomous robots are the next thing. And this is the first time this is the only technology which can actually change the biological complications. The leak rate of a human being and the leak rate of a robot might be different because the robot is doing it in an automated way. Miniature and micro robots these are very fine robots. You swallow them, they go into the intestine, they can navigate their way, enter into your ampulla of water, enter into the bile duct, fire laser at the CBD stones, break them, and then they can get biodegradable or they can come out. So this is very revolutionary. It can completely put the surgeons and the endoscopists out of business, and it can also recreate lumens in inoperable carcinomas. It can go and place stents and drain pus. Soft robots is another thing which you should be familiar what it is. Robots are generally known to be rigid instruments. Soft robots are very pliable instruments. It's just like your hand touching a structure. If you can touch a wood, you can touch iron bar. Your skin actually is soft. It can actually sense the pressure. It can mold itself around it. Soft robots can manipulate themselves. They are like elastic air-filled balloons which can navigate through narrow spaces and then go and deliver the job. There is something called theranostics, which is important, which is a combination of diagnostics and therapy. So you can have a robot which can go into your colon, do a complete screening colonoscopy. During the same time, if it finds something suspicious, it can go and look at it with a very close endocyto microscopy. It can decide if the polyp is benign or malignant. if it decides it's malignant, in the same sitting, you can even do a resection of the polyp. So you start off with a screening colonoscopy, and half an hour later, the patient is screened, his entire disease is mapped, and doubtful polyps are even excised. All this comprised in theranostics. So that is the next thing, which is very much in the advanced clinical trials. You can see the robotic tip, which has got multiple ports. There's an ultrasound which comes out. It studies the polyp's nature. Then you can have a continuum robot, which we spoke about earlier, coming through that with 2 arms. It can actually resect and remove the polyp. So if you think the future of surgical gastroenterology is robotics, it is definitely not. It is integrated. We are moving from era of mechanical innovation. We start finding more and more mechanical devices and thought we are advancing, but that era has come to an end. Now is the time for technological convergence. Like you have to use multiple assets to converge and then improve your outcomes. So this will decide when we operate, why we operate, and in some cases, whether we operate at all. So future of GI surgery will not be by a single machine's invention, like laparoscopy or robotics or something more. It would be a convergence of robotics, AI, advanced imaging, soft robotics, endoluminal platforms, micro-interventional systems, and the list is continuous. So this is something for us. We may not understand the entire gamut of this, but we should understand that we are no longer restrained or decided by the mechanical excellence of the equipment we use. So you might wonder why on a nice post-lunch session, we should be talking about all these things. Are we going to design new instruments or technology? Definitely no, that is not a cup of tea. We are after all an end user. We will wait for the product to get launched. Let the representative come and tell us, and then we will decide if it's viable, we'll buy it. Why we need to know that is, as clinicians, we have a major role in asking the right questions. If you create the demand, they'll create the solution. So that responsibility is there for all of us. You just had Dr. Haribhakti tell us about his entire spectrum of innovations. All innovations are the birth of the correct question being asked. You create and define the problem, there is always somebody to solve it for you. And that question will come only from us. We can also adopt technology from across specialties. You might find something being used in a different specialty. You might actually see and find a role that you can employ it in your own specialty. This will not occur to the person who has developed it because they are working in a very narrow field. And most importantly, you have to survive the changing trends and be relevant. So you should be keeping yourself abreast of what is happening in the other space. So as senior GI surgeons, your role is no longer just an operator. You have to be a strategist. You should be technologically literate, and you must be able to do value-based adoption and also leadership in training and implementation. So we have had a small tryst with how you adopt technology across specialties. Like there was a technology from a Korean company which was using actual projection of the CT images of the patient to map the location of the brain tumor so they can actually plan their incision. So there is an iPad sort of thing which they see the patient's head with it, and then you can actually map the vessels, and then they decide where they have to put the incision. So when we saw this, we thought we'll adopt it to our use. So we decided ETEP is an operation where you need to know exactly where the rectus muscle is. For people who are doing ETEP will be able to relate to this. So if you know the exact map of the abdominal wall, you might actually be able to place your port in the most efficient position. So what we did was we loaded the same abdominal CT scans. We started projecting it on patients, and then we started mapping the abdominal wall with this. So what helped this did was the most crucial step or the first step of putting the port. The senior surgeon need not be there in the theater. Anybody can put, because he is actually, the abdominal wall is completely traced on the skin. You can place the port exactly on the lateral border of the rectus muscle and enter into the rectal space. So this is the first and most rate limiting step of the operation, which was made very simple. And we are also, there are other technologies that are coming in. There is something called a 3D scope technology where you can actually have the entire image projected on your eye. So you're no longer shifting your head to look at the screen. So you can actually intuitively look at the field of where you're working. If you're working in the right upper quadrant, your head can be aligned with your body to the right upper quadrant because the image is right in your eyes. Ergonomically, this gives a lot of comfort to the shoulder. We are actually doing a study, doing an EMG recording of the shoulder muscles using a VR glasses versus regular screen looking laparoscopy. They're just two small examples to say that You can adopt technology from other places. You can create and define the problem to the technologists for them to come up with a solution. And every small thing matters because nobody is going to come and solve a gastroenterologist solution unless he gives a problem to them. So the next revolution is going to be cognitive, predictive, and biological. In this, definitely we will play our part in the cognitive and the predictive part, because we're not basic scientists. Biologically, we will not contribute, but it is important to know what is happening in the space around us. I will want to reiterate what Sikora sir today said. Like, if we have seen further than others, it's only by standing upon the shoulders of these giants. I would take this opportunity to test and place the gratitude on the feet of those giants who are sitting in this hall and outside this hall. Thank you.
Now we can discuss any questions. Next speakers will be happy to answer. I think in the interest of time, we will start this session. Thanks a lot.
Thank you, everyone. There is a small announcement to make. I request all the alumni members to kindly cut the certificates and the gift packs from the reception counter before they leave. And one of our faculty has misplaced her iPhone in the venue. So I request you to kindly check your seats nearby. If you find any, then please report to us. Thank you.
Now we'll begin with session 4, that is on training and specialization in surgical gastro. I would request the chairpersons to please come upon the stage. Dr. Rajan Saxena, Dr. Anshuman Pandey, Dr. Wasif Ali, Dr. Saurabh Galoda, and Dr. Nisar Handani.
एजीवी मेरा पेन ड्राइव में एजीवी करके होगा फोल्डर एजीवी अभी किसका है होने वाला है अभी जो फटाफट चलता है ये है लखनऊ ये दोनों कर लीजिए सेशन 4 में ये दोनों हाँ और ये कौन सा और ये सेशन 5 में कर दीजिए इसका क्या है जीवा किलर लगी ना आपको हाँ चैलेंज से आंसर करें कौन सा वाला सेशन ये ना बी बिजू ट्रांसप्लांट ये इसका हो गया ना ऊपर
I would request Dr. Pradeep Ravela sir to please come up on the stage as chairperson.
Dr. Ragini, please chair the session for us. So may I request the chairpersons to please invite the speakers.
So I now invite Dr. Shalini Agarwal. So I now invite Shali Nagarwal from the Department of HPV Surgery and Liver Transplant at Avinash Institute, Hyderabad. Deliver the first talk of this session on organ transplant training, when and where it starts.
Thank you, Dr. Ragini. And thank you, Dr. Anu, for having me here. It's always a pleasure. So I've just taken the liberty to add this word liver because this is the organ that I've been working on. So basically, all my slides and my experience is based on liver transplant. So I have added the word liver in the brackets. So just a little background, what organ transplant as a subspecialty. So this is a common misconception, I would say, that surgical expertise on a particular organ, that is, if you are operating on the liver or the pancreas, you automatically assume that you have the expertise of transplanting that particular organ. So this may not be exactly true because organ transplantation requires comprehensive knowledge of not only the surgical aspects, but also the medical aspects, including immunosuppression of that particular organ or organ system. And it involves a paradigm shift in your thinking process, your approach, which doesn't come just by gaining surgical expertise on that particular organ. And it develops after a lot of experience, after many years of working in the transplant arena, despite the fact that you have a lot of years of experience on operating on that particular organ, and in this case, that's the liver. So it's all about a shift in your thought process, which will ultimately result in successful outcomes. So what are the components of an organ transplant process in general? It is the preoperative aspects, that is whom to transplant, timing of transplant, and when not to transplant. That holds true for any other surgery as well. But in the frame of transplant, you need to answer all these questions. Of course, the surgical expertise is essential because, for example, in liver surgery, operating on a background of cirrhosis and portal hypertension is very different from any other liver surgery in a person who doesn't have portal hypertension. So you need an extra skill set. Post-operative care, it is as in the case of transplant, it is and particularly liver transplant, and that's so living donor liver transplant, it's at least as important to the surgery itself. Successful surgery, unlike other GI surgeries, is only the first step towards a successful outcome. Because you do a good surgery and then you can rest in peace, okay, this patient will go home in majority of the cases. But that is not true for a living donor liver transplant because surgery, a successful, flawless surgery is only half the battle won, because most of the complications these days are not related to the surgery, provided the surgery has been done nicely. And still, despite a very good flawless surgery, you lose your patients. And the biggest problem with transplant, especially living donor liver transplant, is that it still carries a finite mortality to the tune of around 8 to 10% in majority of centers around the world, despite the surgical processes being nearly flawless with very little blood loss or very little transfusion requirements. So this is the biggest problem with liver transplant. And other is ensuring long-term outcomes. So we feel very happy, okay, we have done this many number of transplants, and we boast that, okay, our center has done 400, 200, 100, whatsoever is the number. But actual success lies in keeping these patients alive in the long term. And that has been the major shift over the last few years. If you go through most of the recent international journals, the literature has shifted from surgical expertise, because I feel majority of the macro surgical aspects of transplant, liver transplant particularly, have been already been covered, including a robotic recipient and everything. Now, the shift has been to how to keep these patients alive in the long run. And as Partha just said, that we are shifting towards not only survival, but also the quality of life parameters. And therefore, most of the recent articles are focused on these aspects. So when we talk about transplant training, so what we think is, okay, I have learned to do the surgery and I'm a transplant surgeon or whatsoever. But that's not exactly true. Because as I said, in liver transplant, especially LDLT, a successful transplant is only half the battle won. There's a lot of fight till the patients get discharged. Most of the patients are dying because of non-surgical complications. And secondly, keeping these patients alive in the long run, which involves a lot of hard work, keeping these patients under close follow-up. Non-compliance, recidivism, medical conditions, malignancies are the common problems that we face once your transplant program is 5 to 10 years old. So why training in organ transplant? One, because GI surgery, and this is, I'm talking with respect to people who have already done their fellowships or have gained experience in GI surgery. So GI surgery has become too vast a subject because of the rapid advancements in the technological aspects, the surgical aspects. And therefore, you cannot expect that a 3-year MCH course or a DNB course or any other 3-year training will give you adequate exposure to make you a competent liver transplant surgeon. Therefore, focused transplant training is required. It is the key if you want to independently pursue a transplant career. However, before I go to the topic proper, that is when and where to take the training, there are a few words of caution. And all the slides that I'm putting, I couldn't find any guidelines or rule books or published literature to suggest when and where to get the training. It's just what I've learned or got some insights during the last 20 years. So these are the few words of caution that I would like to convey to the young surgeons who want to pursue or venture into the field of liver transplantation. Do not be victim of a FOMO syndrome. Do it only if you like it. It's not just because my colleague is doing it or so many people are going for transplant, I will also go for transplant. No, just be independent, think independently and do it only if you really feel like going into it. And most importantly, and this may be a bit controversial statement, but I still want to reiterate it, that do not treat liver transplant as one of the procedures in the gamut of GI surgical practice. Liver transplant, especially living donor liver transplant, needs full-time attention. Okay, you may be having department, but a particular set of surgeons should be focused only on transplant, especially living donor liver transplant. You cannot be doing a colorectal surgery one day and next day transplant, and then after another 20 days or 30 days, you're doing another transplant. You cannot match the outcomes of specialized centers. And that we owe to our patients, that we have to give the best outcomes. So this is my view, that surgical practice these days should aim at performing a few procedures perfectly rather than doing many procedures with average outcomes. So it is a common, like, like we want to do everything. So we should get rid of that or refrain from getting into that trap. Just focus on a small area. See, why we go to the west or to the east to see certain specialist surgeons like Dr. Hari Bhakti traveled around the world for short stints to learn particular surgeries, because these surgeons or these particular gentlemen had focused or dedicated their entire career to doing one particular or two particular procedures. And that's why they were able to publish, get a name for themselves. They have done 1,000 pancreatectomies or 1,000 Whipples, 5,000 this surgery. And so they made their name for themselves. And it's not only about the name, they produced excellent results. And those results in surgery or in any other field, technological field, would come only by repetitively doing it repeatedly, frequently, again and again, picking out the small flaws. See, anybody can do a liver transplant. I tell you, it's not a difficult thing. You train for a few years, start doing, but then getting that 99%, not 70% result is the key. That how can you make these patients survive longer and without complications? There are a lot of long-term things. When we talk to our colleagues and we often discuss, okay, we have done 500 transplants, but how are your patients doing in the long run? So many patients land up with biliary complications, early chronic rejection. We just never, these things are always brushed under the carpet. You cannot do that if you are doing everything at the same time. One day you are doing an esophagectomy and the other day you are doing transplant. You can never get that result. So this is my request, that try to focus on a small area, and this is the way to go for your personal satisfaction as well for better outcomes. Forget about the glamour. There is no glamour attached to liver transplant, and there are much simpler and better ways of making money. So I would just want to make these 4-5 points before we talk about training proper. So when to start organ transplant training, and when you talk about when, then there are certain key considerations. What are your professional goals? What is your basic training or the groundwork that you have already made? And then there's certain personal factors. We are all human beings, individuals with families. So personal factors gain importance. So what are your professional goals? Do you want to pursue a career in organ transplantation, that is liver transplantation for GI surgeons? Or you just want to have an experience of working in transplant center and want to see how that procedure goes, and whether you are just testing the waters, whether you want to do it or not. Or there is a set of surgeons who want to improve their surgical skills and patient management skills, because your anastomotic techniques, your vascular surgery, all of them, they improve. Even if you are not doing transplants, you will become a better GI surgeon. So these are the three sets of goals that one can set for oneself, himself or herself. So that will depend on how you train. Then about the basic training, experience in GI surgery definitely provides an edge. Although in the United States, most of the transplant surgeons have a training in general surgery, but their general surgery training lasts for 5 years. Unlike India, So best would be if you have a training in GI surgery, even if you have not had significant exposure to liver surgery, but GI surgery is different from general surgery. It's again about the mindset. So GI surgery, many of the experienced general surgeons would say, I do everything what you do, but there's no point in arguing because it's about the mindset, how you do. A GI surgeon is not a general surgeon. Similarly, a GI surgeon cannot claim to be a transplant surgeon unless he has dedicated certain number of years or worked intensely in that field. If you're not a GI surgeon, then you should have a background of good general surgery training, which should be at least MS followed by minimum 3 years of an intensive residency in general surgery. So this is the basic training that is required. Coming to personal factors, try to start your training. If you are made up your mind, then it's better to start early after you're completing your basic training. Don't waste your years here and there because age is just not a number. Often it's said, oh, I can do it anytime. Age is just a number. I don't believe it because as years go by, many things change and proper training requires focus and energy, which may not be possible. Like at 30, 35 years, you may be able to dedicate your entire time for training, but that may not be possible at 45 or 50 years of age or even at 40 years of age. So try to enter the training process early, and then a favorable family environment is a great advantage. So how to select a center for transplant training? So it depends what is your goal, and the 3 goals that I mentioned. Want to have an experience of working at a transplant center. So a small 3 to 4 months stint at a high volume center doing both living donor and deceased donor should be good enough. It would satiate your curiosity and maybe you'll be able to better decide whether you want to pursue a career in transplant or you just want to improve your skills. So if you want to improve your surgical and patient management skills, you should be spending at least 6 to 12 months at a high volume center that is performing both LDLTs and DDLTs, because don't expect to get any hands-on work for at least 6 to 8 months. So if you want to improve your surgical skills, if you want to assist, you won't be able to get a first assistant position for the first 3 or 4 months. So you should be prepared to spend at least a year at a high volume transplant center if you just want to improve your surgical skills and you want to improve your patient management skills, and you're not willing to pursue or intending to pursue a career in transplant. So 1 year should be good enough for that. Now, training for transplant as a career. So factors that should be considered while choosing a transplant center. And these are some of the factors I considered when I was applying for my fellowships in the United States many years back. So these were some of the factors, and I've added a few more as I've gained experience in this field. So case volume is very important. Ideal center for training should be doing around 200 transplants per year, which should be a mix of LD and DDLT. So if the numbers are less, you won't get enough exposure. On the other hand, if the volumes are too high, you will be just busy preparing patients for transplant. You won't get much surgical exposure because those centers, high volume centers, are aimed at pushing those patients, completing the surgeries. Training takes a backseat. So ideal case mix would be like numbers would be around 200 transplants per year. You should at the same time be able to get some exposure to complex HPV procedures because you will be doing those procedures in your practice. Exposure to minimally invasive procedures is essential, especially robotics has come in a big way in liver transplant, both in donor surgery as well as now it's venturing into, people are venturing with robot into the recipient surgery. Also, duration, ideally you should spend at least 2 years in a average volume transplant center if you want to be a little confident and you want to go independent into the field for doing transplant. So at least 2 years. Faculty, look at how's the faculty. It should be a mix of both experience and youthful energy. Many centers, there are new centers, multiple young people who are themselves learning at that time. So there is no point in doing a fellowship because you will not be able to get much training because your mentors are themselves learning at that point of time. So it should be a mix of experience and energy. Centers should have a focus on training and mentoring. What is happening that fellowship programs in every field, including liver transplant, are coming up left, right, and center just because there's a shortage of working hands. So don't choose a center where fellows are being taken just to increase the number of working hands. It won't be of benefit to you. And therefore, select a program which has a proper selection process and exit benchmark, some exit exam that makes that a structured training is very important. And that's why when I was choosing for my transplant training, it was very easy to go to UK. Most of the people in my time were going to UK because there was no exam, nothing. You could easily write a letter, get a recommendation and go and enter and my seniors also and could spend a few years and get training. But then I got some advice and then I applied for my MLE and went to United States just because it's a very structured program there. What will you be doing in the first 6 months, next 12 months? It's a 2 years fellowship. So same thing I would like to convey to you, that when you are choosing, choose a program where there is a structured training. You will be at least guaranteed that what you would be learning at the end of your 2 years. And there you are supposed to maintain a logbook, and it is tested by your examiners at the end, that how many procedures you have done as independent surgeon, how as first assistant. So proper selection process, exit benchmarks, and certain structured training is very important. Just don't go pick up a big name and enter a transplant program which is doing large number of transplants, but at the end of 2 years, you may be getting very little out of it. Therefore, how old is the fellowship program? What is the reputation? Check with your colleagues. And so don't go on the internet, check with your colleagues, because they are the best who have done or worked there, will give you a much better idea of how the program works. So this is very important. Conducive working environment is very important, because if there are large number of fellows working in a one center, then it becomes a very toxic environment. So that again is a very important consideration. Choose a program where every year they are taking only 2 or 3 fellows, because then you will be able to get some individual attention. And then fellowship should always provide a stipend at that point of your age. You need to earn money also at the same time. So these are, I've made a checklist, which I think would be helpful. See, this is an ideal situation. You may not get an ideal situation everywhere, but if most of the boxes can be ticked right, then that would be the right program to choose for training. Do you need to travel abroad? Definitely no. But it is not possible for a single center to have mastery in all aspects of transplant surgery. So therefore, short stints for learning specific procedures or skills are always helpful. So that is my last slide. GI surgery is a vast subject. GI fellowship cannot provide adequate transplant training because it's too broad now. Factor in your career goals, prior training, and personal aspects before deciding to go for transplant training, and then follow the checklist for choosing a transplant center which you can provide the best training for you. And most importantly, traveling abroad is no longer required for a liver transplant training. We have so many good centers available in India. Thank you very much.
Any questions? If there are, we proceed to the next topic. We have a dear Dr. Biju Kotakar, Professor and Head Department of Surgical Gastroenterology, JFK Pondicherry. He'll be speaking on surgical gastroenterology, education and training. Do we really need to change, and how?
Actually, morning when I came, my super senior Dr. TD told me that हम भाषण सुनने के लिए नहीं आया, मस्ती करने के लिए आया है. So lecture कब करो? So नाम गलत तरीके से. So I reduced my.
नहीं डॉक्टर बीजू उनको ऐसे ऐसे कर रहे थे, ऐसे रोको. मैंने कहा आप अभी चलो, मैं ऐसे ऐसे करूंगा.
That is not working actually. So I don't know, I'm the right person to talk about this in front of esteemed teachers. I'll just give some of the inputs. So this is the medical schools, how we learn. It's a department-oriented, school-oriented architecture we learn. So the problem starts with our specialty itself. So unlike neurosurgery or cardiac surgery, other centers, if you go, there's HPB, upper GI and colorectal. So this started in 1980s in India, this the surgical gastroenterology. So you're ought to operate colorectal and liver, which is totally different ball games altogether. So what really happens in this mixture, hardcore works like transplant and all that is not happening. Okay. Second is department became one of the sources of learning and training. So maybe 25 years back, departments were the only source of learning if you're a trainee. Now there is a lot of knowledge transfer happening by online conferences, meetings, and other media. So department trainees consider departments as one source of learning center. So this, as teachers and mentors, we should be very aware that we are not giving them 100% training, nor they are expecting. Third is, we are getting, fortunately, compared to neurosurgery or CTVS or pediatric surgery, we are getting top trainees in the country. But what is happening is, right from the MBBS training, the curriculum is designed in such that there's a strong theoretical background is what is trusted. So you get a strong theoretical background trainees, and they're struggling to correlate the knowledge and practice on the bedside. So you have a lot of knowledge in the theory side, but what actually happens and how to apply is a bigger problem. You are varying clinical materials, surgical exposure, increase in number of tests. So all these trainees suffer from this shift in the ecosystem. And when any department put that, okay, I want to produce a complete training in 3 years in MCS, it's practically becoming increasingly difficult even the best centers. So the problem is they're carrying a lacunae of clinical training in MBBS MS and study leave periods. And these MBBS MS becoming a pre-qualification criteria for MCH. So 3 years becoming very insufficient to produce a end specialty trainees. So this is a fact we are facing in the ground. Now, when you have this fact, we try to put all these departments in the same portal. Okay. But please do remember that we have IAS academies, we have premier colleges like IIM. So in the premier institution should produce extreme trainee products, because there are some diseases and problems in our country or in our specialty. Who is going to manage when you talk about 8-hour jobs or Sunday off and all that? This is not the category of the products we should produce. So premium institutions should produce extreme trainee products who can handle everything in the process. So we need some 20 to 25 people per year. Otherwise, this specialty will not be able to handle the complexity of the specialty. So premium institutions should focus on a different method of training altogether. So this is a little bit of a complex exercise. So practice to faculty, trainees, department, ward, ICU, all this create your environment system. So what happens now is every ecosystem where faculty is very important, faculty should have a subspecialty as a domain. We can't claim at this era that I am the master of all. So generally 30% each clinical teaching and research and 10% administration fact. We probably maintain this factor, you can be a good teacher. So we can't tell that I am operating for more than 50% of the time, and that will spoil the ecosystem. So research is practically will take a backseat because of the specialty. So my small input is, do not try to push too hard research to this MCS trainees. It will not work that way. If you want to do too hardcore research, please hire PhD people or other people and try to put hardcore randomized trials into them. These people came for basically for training of clinical areas and do some dissertation and other works. And there is a change in classroom atmosphere. So maybe 25 years back, we used to discuss about journals and books and memorizing so many things. And we try to tell everybody, impress that we are the masters of the knowledge. I remember this page, that page, but that is not what a new trainee expects. So what they expect is, we know or we can find out the information from journals and books. What is beyond that? In this particular case, what I expect beyond what is not there in the journals and textbooks, this should be our focus of discussion in the classroom. So it should be a more patient-centered training, familiarity with the pathological and prognostic process. So every trainee, let us say department is handling only pancreatic cancer which are resectable, and he has never seen a patient with an advanced pancreatic cancer in real life and managed, that will be a problem in training. So all of us should ensure that they are seeing all the stages of disease, various pathological processes, how the natural course of the malignancy develops and metastasis, all this we should know. And multidisciplinary meetings are very important, which is the dictum of the day. And some of the very newer must-learn areas, I'll just list 10 to 11 areas. One is the real-time navigation. So all trainees should know how to actually do a real-time navigation. Real-time navigation is currently on ultrasound base, but we should know how ultrasound you can do, how an intra or laparoscopic ultrasound should be done. So it's very important for all areas. Second is we also need to know the advanced radiology and reconstruction platform. So basic radiology, putting X-rays or seeing the films in the computer, mobile platform, it's not enough at all. You should know what is the 3D construction you require and how to make that 3D reconstruction according to your needs. So less depends on radiology, like neurosurgery has progressed in that way. We are only in the beginning. So we should know the advanced radiology and reconstruction platform. Third, we should know the fluorescence as well. So the importance of fluorescence is going to come both as positive and negative fluorescence as well. So this fluorescent technology is going to or already transform, but is going to transform in a much bigger way. Four is the familiarity with the AI tools. So this AI tool, as you know, AI tool assists us. Currently, we have the enhanced images. So you put something in the CT or contrast and the machine will tell you enhancing, but it is actually not required in the near future. You know that urine is different, bile is different. So without any contrast enhancement, the tissues are going to give you a perfect calibrated image of each organ. So you have to be familiar with the new AI tools available. The second most important is, now we were discussing only about the real images which are enhanced. Now the AI tools are so powerful that it will give you a totally surreal images according to the surgery you need. So for example, you operate on a Callet's triangle cholecystectomy, you put the camera in that particular area, only the Callet's triangle, it will enhance and give you the images in the whatever you want. You want the hepatic artery in red, it will give you. So we have to be familiar with working on surreal images. You know that in laparoscopic surgery, we are not seeing the patient. We are already operating only on images. We are not actually operating on the patient. We are operating on images. Now, the next era will be operating on non-real or artificially engineered and surreal images. And this will also transform to immersive reality appearance. So we have to know that what is immersive reality, how immersive reality will transform the operation room environment. Then we should have familiarity with these smart instruments. So this is the crude instruments, what you see, what you are going to see every day in your OT. But what is going to happen, these instruments you are putting inside the body, the instruments also, AI will create an artificial image or function of these instruments, and it will make sure that these instruments are for a particular methodology or particular function. For example, you need a grasper. It will show you a grasper in a totally in an artificially engineered picture. You will not see the real grasper, a particularly created for that particular purpose. So this artificially engineered instruments are going to come in the market very soon, and exposure to new energy devices also. In the vision front, what is going to happen is probably the 4K, 3D and all that came. But one of the problems, negative effect of that is we started seeing more and more structures in the human body. Even if you take Gray's Anatomy very well, the structures which is seeing with the high density, high resolution is much more than what is described in the best anatomy textbooks. So these images are images coming out of the operative field are going to be very real. And another important factor is these images are going to be artificially engineered, and it will come to different sizes, different color, and different dimensions also. So please be aware that the operative field which you are going to see in the near future will not be the real image. It will be a really change. So the new trainees need to be familiar with this sort of surreal vision and tissue-based vision. Tissue-based vision, for example, now we have a fat suppression or fat enhancing vision also. You want a particular area to be enhanced. It will be a very without non-dye tissue-based vision. And robotics are going to come in a very big way. So most of the data coming from across the world clearly point at a very strong trend that this robotic technology is somehow going to probably kill the robotic, the laparoscopic system altogether. So you are basically working on minimally invasive techniques. So once the robotics comes into an instrument tip and your vision field improve much better. Robotics is simply a 3D or a higher vision and instrument tip manipulation. So once this becomes much more simpler, the traditional laparoscopic system, whether it is 2D, 3D or 4D, is going to practically disappear. So this laparoscopic system probably is going to for an extinction. That's what I assume. We also in educational setup, we need a lot of simulation system. Why do we need simulation system? If you remember the points which I told till now, these points, the previous 8 points, you cannot be learned from a human body. Okay, this can never be learned from a patient. Okay, altogether. So in order to learn that, you need a very high-end simulation systems. It may cost several crores, but it is very important that these simulation systems are correctly installed in our department. Then only we can produce a complete training. And also, please never forget about the patient safety training. Patient safety is not just about the maintaining the quality. It's totally different. Even the best centers where patient safety religiously followed, you have to follow something more than the WHO checklist and other modalities. You need a patient safety manual in your department. If you don't do it, mishaps like this are likely to happen. And thank you very much. I will stop here. Thank you.
Terrifying aspects when we were finishing our training was actually where we
This one.
That's one. It was as stressful as the exact exam that we were going to. Some of us have actually fumbled initially to reach wherever we are, and probably share his experience just after he finished his thesis. So it's really my pleasure that he is my co-colleague also while we were training in OCH.
So very good afternoon, my teachers, seniors and friends. So when I finished my residency, there were two things which were in the back of my mind and which I trusted very strongly. One of them was the fact that I knew that I was trained. And perhaps the second thing was that I thought that probably the hardest period of my training is over. Unfortunately, I was wrong in both these aspects. Probably your real life starts after your residency has been completed. We as surgeons are in a science that is an imperfect science. We don't remember the perfect anastomosis. We don't remember the cholecystectomies that went well, the 20-minute cholecystectomies, the 5-7-minute cholecystectomies. But we do remember the patients which had a bile leak. We do remember the patients which did not follow the textbook. We do remember the patients wherein the CT was normal, but the abdomen wasn't. And these mistakes extend far beyond surgical complications. These mistakes are on a personal level, these mistakes are on a financial level, and a lot of other facets that we would face in our daily life. The problem is that these mistakes haunt us. We think about them privately, but fail to discuss them on a public basis. This matters because residency is something which teaches us how to operate. My teachers have taught me how to operate very nicely. But it is our practice that teaches judgment. And therefore, we have to look at other parasurgical skills as well. We have to understand that skill is not equal to judgment. And perhaps the hardest operation in the early part of your post-residency years is to say no to a certain patient. It's your overconfidence that actually leads to wrong case selections. These are the non-technical skills for surgeons, which include, beyond surgery, communication issues, situational awareness, decision-making, leadership. These are all the facets that we should also be looking at. And when talent and ambition do not meet up, this is what happens. So there are mistakes which have obviously shaped our practice, which have changed our careers, and some of them are actually career-defining moments. I'm sure all of us must have had these moments. We are always there to try to prove ourselves, proving amongst our peers, proving to our teachers that whatever we are doing is probably the best that we have ever done, or we are the best versions of ourselves. We do take up borderline cases, particularly in the initial part, just to prove a point, wherein the point was probably not more important than the point itself, wherein proving the point was probably not as important as the point itself. And the operations are probably done sometimes to build a reputation rather than outcomes. So this is that song from Imagine Dragons, Whatever It Takes, because of the love the adrenaline in the veins. So this is a song. I play this in my car every day. This is perhaps a part of my philosophy as well. But trust me, this is not always right. Now, these are a few of the cases that I performed after SGPGI. This was 2015. Right after my residency, the first case was a laparoscopic subtotal colectomy. I don't know why I did it. I had attendants who were a piece of nuisance. They hardly paid me any money. but I wanted to do it. I'd never done it during the course of my residency. I'd never done a laparoscopic subtotal colectomy before that. I did it. The patient worked nicely and all went off very nicely. I was an instant hero overnight. But if I were to look back and reflect, this is probably not something that I should have been doing. The second case was actually a politician. This was a very interesting case because this led to my marriage. So obviously this was a wonderful case. And the other one's a pancreatic necrosectomies. One of them I lost. So these are the kind of cases that I started off with. Probably not the right selection to begin with. I ignored the easy cases to begin with. I did not embrace fundoplications. I was too shy to admit that I was also trained in proctology. Probably some of these changes were brought about by my association with Dr. Palani Velu, Dr. Gode, and all these senior members from Amasi. They helped me a lot in shaping how I am today. Also, during the course of my initial 12 months itself, post MCH, I conducted the grandest ever Amasi skill course 2016. This was actually done on the same venue wherein we had SECon 2024. And I actually ended up losing $1 million. I did not lose them in the books. The books showed profit, but I considered the loss just because I didn't want to show that I actually had lost money in this. But times have changed. There is the comeback. Last year, I did conduct perhaps the most successful Amasi skill course till date. That money was never recovered, but at least the reputation was. We surgeons also underestimate complications sometimes. If we remember the patient that didn't follow the textbook, as I already told you, we are always there, bringing out our rare cases, nice case reports, nice technical details, but we don't talk about the real complications that we had. The cholecystectomy patients that we lost, the hernia patient that we lost, we don't discuss about these things. And these complications sometimes are avoidable as well. So this is one of the patients. This was an EHPVO patient. I was operating upon this lady. I thought that this was probably an easier cholecystectomy, although I have done it in the past as well. But see, 1, 2, and 3. And this is what happened. And then there is absolute pandemonium. Obviously, this was a tricky situation. For a moment, I had my heart in my mouth, but I managed to control it. And this is the same patient who has arranged a taxi for me today. So this is actually the situation, what it is like. This patient was salvaged. I managed to control the bleeding. I had to open this case up. So during the course of our residency, the complications belong to the unit. After residency, the complications belong to you. In your unit, there is always a professor, there is always a senior figure who would be standing behind your back. But after you have finished your residency, these complications directly belong to you. I remember an esophagectomy patient. When he had a heart rate of 130, my whole mood will be spoiled. When he had a heart rate of 110 or maybe 100 around, then I'll be in a better mood for the rest of the day. So this is how things work out for us. It's a technical roller coaster that we actually go through in these situations. No man is an island. Individual practice has its own problems because discussions stop. Second opinions are not there. And these second opinions sometimes can prevent disasters. So it's always advisable to be a part of a bigger team because no one can master everything. And certainly, if I were to look at myself, there were mistakes that I committed as a consequence of that. So perhaps it's the case selection, team communication, and early help seeking which actually improve the outcomes, especially in the early part of your residency, in the early part post-residency. The fifth mistake that I can look at is copying careers. So copying careers is something we tend to look at our mentors sometimes. So this is the confusion that we always have, whether we should go for an academic practice, a private practice, or a hybrid combination. Fortunately, I have also developed I have had the best of all three worlds. I have been in the government service, I am in private practice, and I also work in a corporate hospital. So I have got the best of all three worlds. So perhaps we have got our own skill sets. We have to choose which skill set suits us the most and therefore decide according to it. Saurabh is currently working at AIIMS. I'm working in Agra. We are both happy. So perhaps it's what we are actually looking at or what we want out of our own lives that is most important. Sixth mistake is ignoring systems. Good outcomes not only need good surgery, they need good anesthesia, good ICU, nursing, and protocol-based care. So sometimes surgeons tend to disregard these aspects. We don't look at the patient that our anesthetist was probably hesitant to take up. And ultimately, we end up conceding negative results. So therefore, we have to look at these systems as well, respect them. I had to obviously pay respect to my anesthetist because my anesthetist was my wife, especially in the initial years, so I had no other choice. But then you have to actually look at these things as well. And great surgeons do build teams. That is very important because they take up a lot of our responsibility. Obviously, SGPGI training was a lot about documentation, as Anu ma'am also showed us in the morning today, because memory fades, but records remain forever. So we spent years tying knots, but then realized that perhaps the most important knots are in the consent forms. This is one basic mistake that a lot of people perform. And this is something that leads them to the court as well. And then there is no salvage. So therefore, we have to look at these things seriously as well. Another big mistake is ignoring health and burnout. A busy surgeon does not equate to a successful surgeon because fatigue is something which changes your decision making. Am I working more? This is a question that I've always asked myself. This is probably me and this is probably my wife, particularly in the initial years. We were both burning our midnight oil, working tirelessly in the night. And like we had cases like starting at 10 p.m., Whipples would be starting, we'll finish off at 5 a.m. in the morning and stuff like that we would be doing. So this is something that we don't do anymore at this point, but definitely we did it in the initial part of our learning curve. Let me just ask you a simple question. How many among us have HbA1c in the normal range? I can trust you that the number would not be more than 30%. A lot of us actually fall into this particular category. Then comes this financial disasters part. Now, financial complications are perhaps those complications that we tend to overlook. As our practice grows, our finances also grow up. But the problem with us surgeons is that we surgeons are smart people. And smart people don't commit mistakes. We commit blunders. Why? Because what happens is our logic is something that gets blinded when we actually are in the scheme of looking at things. We tend to look at things emotionally. And therefore, we make these financial disasters. And also, no residency program in the world trains us how to manage financial issues. We were trained to manage pancreatic leaks, but not partnerships. So one of the biggest traps that is there is the partnership trap. We tend to look at verbal agreements. We tend to look at unclear revenue splits. And therefore, we end up conceding conflicts and losses. So one of the problems that we surgeons face is that culturally, it is regarded as a taboo. We tend to regard it as a taboo discussing financial issues with other people just because we don't want to look greedy. We don't discuss these financial aspects just because we are not supposed to do that. We are a surgeon. We don't have to discuss these things with the hospital management, but these are our own finances. We have to be smart enough to look at these issues as well. Second factor is failing to look or failing to price in the cost of the consumables, implants, meshes that are there. We tend to give our patients packages, particularly in corporate hospitals, but then there is a package mismatch. And the patient actually is the one who's at the receiving end. And this leads to patient distrust and erodes his confidence into us. The third issue that plagues us is reputation versus revenue. There is this discount competition that is going on. People, particularly in the early part, would give heavily discounted surgeries. But trust me, cheap surgery for a career is more expensive. It's your reputation that compounds long term rather than these discounts. These discounts never really compound up. Fourth issue is probably infrastructure and debt related issues. So we tend to look at ownership as something which is very important from the standpoint. Ownership of a hospital is very important from the standpoint of a surgeon. And there is a certain amount of peer pressure as well that is there. But we should look at these things very seriously because we have to understand whichever thing that we are looking at, whether it is actually necessary, whether it is something that we need or something that we want. So therefore, volume is something that should precede any kind of investment, and buying equipment early, particularly in the initial part, or getting into a hospital thing, particularly in the initial part, can be a real problem because this is your EMI pressure that actually affects decision making when it comes to your surgical aspects. So just look at these two small establishments. This is one of the shops which actually technically qualifies as a Dukaniya in UP language. And this is the corporate hospital that I work in. The small shop fetches me millions. This fetches me peanuts. And actually, this is on the verge of sale as well. I was one of those persons who was in the auction of this hospital. This was Meera Radia's Naiti Hospital. So this is how things work. Things may not seem the way that they are. So a busy surgeon becomes rich. A hurried owner becomes trapped. That is the problem. Loans, obviously, a lot of people among us may have taken a certain amount of loan at a certain point in time as well. Not all loans are bad, but we have to look at those loans only which amount to financial leverage. Financial leverage per se is good. Loans are bad. This is me in 2012. I used to transport a lot of people and I was very happy transporting my teachers all across the SCPGI campus. I'll pick up everyone from the airport and transport them and drive like Michael Schumacher would do. And this is what I used to do. So, but in SGPGI days, I used to spend approximately 75% of my stipend as EMI for this particular car. I've got another car now, which is slightly longer than the one that I earlier had. And now I claim 40% depreciation on that. It's an EV. Tax and compliance related issues. So we surgeons are good at planning 6-hour cases better than those 30-year taxes. There is no financial planning. Financial literacy is lacking among surgeons. And obviously, at the end of the day, we concede penalties and stress is there. We don't meet our CAs that often. We meet them only at the end of the calendar year. So that is another problem that we face. In fact, there is a small thing that I would like to emphasize upon. A lot of us are into this business of getting money from online consultations into our personal savings account. Now, what happens is a savings account is meant for savings only. So unless you are a government working in a government institution, if you're working in private practice and if you're taking your money directly into your savings accounts from multiple individuals, that amounts to multiple transactions, tax-related confusions. Obviously, technically you can do that. That is not wrong. But that is something that attracts income tax guys. That is something which is a failure of compliance. And at the end of the day, what is going to happen is after 2 or 3 years, you will be slapped with an income tax notice demanding 20% penalty. And 20% penalty would amount to something like 50 lakhs to 1 crore or something like that. And then your CA will enter the frame. He will reduce this penalty, take some money on it at his end and give something to the income tax officials. So avoid getting into this kind of trap. Open a professional current account and compartmentalize your income taxes. And this is me. I have not taken all the decisions very nicely. I have taken some good decisions. I have taken some bad decisions as well. But at the end of the day, I'm moving ahead. My wife says that you are sometimes like a kachra truck, throwing some garbage here and there, and then but still moving ahead. Mistake number 10, avoiding social media. Earlier reputation spread by word of mouth. Now absence online creates doubt. That is a problem. Earlier, good surgeon was known by referrals. Now, good surgeon is also judged by Google reviews written by a cousin of the patient. This is very important. Despite being good speakers, we are not there online. We spend a lot of time on WhatsApp and all these chit-chatting and everything, but we are not there online. And online presence is something which our contemporary patients recognize. In fact, if I were to look at the best surgeon in my city, he's not even a GI surgeon. And the best gastroenterologist in the city, he's actually not a gastroenterologist. He's a person who was trained in some private institution, badly trained surgeon, doesn't know how to operate, but he calls in GI surgeons to operate for him. He's smart. He's smarter than me. Mistake number 11, and perhaps the most important mistake, is ignoring family. Now, in the early part of our careers, we never miss surgeries, but we miss the ordinary days at home. We think that this is dedication. But if we look at the other aspect of this thing, my son who's there, he doesn't recognize how many lives I save, but he recognizes how many Sundays I'm not there. And this is a problem because our family tends to adjust to these things silently. And then absence becomes a routine. And because of this, success as work coexists with emotional distance at home as well. And this is something that we should all remember. The problem that we all of us face is that we tend to prioritize stability for these things. We think that once we are stable, we'll look at these things. But by the time, life would have already moved ahead. That is the stark reality. This is another example. Why I put this thing is, this is far beyond the pain inflicted upon those poor individuals who were hurt by that car crash. I've got a senior who lives in a nearby city. His son did a similar thing. He ran over a few individuals. He was arrested, got out on bail, and did it again. Obviously, his wife belonged to a political family, and that may have contributed sometimes to this mindset and whatever it is. But at the end of the day, the goal is not to deny comfort to our children, but the goal is to prepare them before we empower them. So just giving them wealth is something which can give you speed. But with speed, you need to have control. Big power comes with big responsibility as well. First, teach them control, then give them control. Otherwise, you'll have incidents like these. In fact, it's more important than everything that is there. It's your presence at home that matters than the hours that we spend. And importantly, we need to arrive at our homes mentally rather than physically. Now, I was also guilty party on a lot of things. My wife always keeps complaining about these things, but I was not there at the time of my second childbirth. I arrived half an hour late. Obviously, she had informed me late as well, but then this was also a part of my duty to actually be there at that point in time. This is something that always hurts me. So, if we were to look at an honest assessment of ourselves, we should ask ourselves what we could have done differently or what we would do differently today. My sincere advice to young surgeons is to choose longevity, protect your sleep and health, audit your own complications, because progress is obtained a step at a time. The goal is not to be a great surgeon quickly, but a dependable surgeon for 30 years. Your work will speak for you. Your advertisements, your publications will advertise for your innovativeness. This is how these things work. I remember this quote from Rajan sir. He said, he used to say in our morning rounds, "Mera ladka kabhi nahi harta. Ek tarasha hua hira, a cut above the rest." These are the things that inspire us. This is me these days. Recent photograph, I asked AI to create a caricature of mine. This is my wife. And this is what it looks like. My wife is there with the patients, wearing a stethoscope, but I'm looking at stocks and all these things, because probably I'm looking at AI, all the things, rare earth minerals and everything. I'm searching all these things on AI. Hang on. So at the end of the day, it's our great teachers that inspire. So maybe experience is not about the number of surgeries that we perform, but by the number of decisions that we would now take differently. Thank you.
Thank you very much for this high energy talk. Nice. With this, we finish the session.
Thank the chairperson and speaker for the wonderful fourth session. Now moving on to the fifth session, I will be an announcement here. Alumni kindly I request the alumni kindly take the gift pack and the from the counter and the memento from the counter, please. Moving forward to the fifth session, research and publication, cracking the code. I would like to request the following chairpersons to the dais: Dr. Shabi Ahmed, Dr. Selva Kumar, Dr. T.D. Yadav sir, Dr. Bhottakat sir, come to the dais.
Waiting for the boss to come. We're moving to the session 5, research and publications, tracking the code. I think the first lecture had already been taken by Dr. Grazula in the morning. And we move on to the second lecture, research in SG, challenges and the way ahead by Dr. Ragini. So I welcome Dr. Ragini and please go ahead.
Thank you, sir. So at the outset, I had like to thank Anu madam for the personal effort that she has put in, which has culminated in all of us being here present for these 2 days. So research is probably something that is close to every SGPGIN's heart. And I'll be talking a bit on the challenges and how do we go from here. So research is nothing but a systematic way of finding new knowledge or understanding something better. It entails asking questions, collecting information, analyzing it, and reaching a conclusion. This question needs no answers for somebody who has been associated with SGPGI, but just to set the ball rolling, we need research because we want to become better. So better is the only word that answers this question. We want to improve our outcomes, better selection of patients, better selection of treatments, drugs. How do we lower our costs? How do we utilize resources better? How do we formulate guidelines? How do we guide administrators into into allocating resources more effectively? How do we develop public policies? Finally, if there's a problem in your house, you are the one who has to fix it. Nobody else will come and do it for you.
So our problems need solutions from our side. Indigenous problems will need indigenous solutions. So research runs a spectrum from basic research, where you can look at the pathophysiology of diseases, to applied to clinical research, where you look at patient outcomes, lab-based bench-side research, translational research, patient-centered outcome, qualitative research, or quantitative research looking at numbers and outcomes. So why are we talking about research in surgery? It's because if we look at data, surgical trials are much smaller in number compared to trials which are medical. This is CTRI data published in Indian Journal of Surgery in 2021, which showed that only 0.8% of trials registered over a period of 2018 to 21 were surgical, or that is basically they arose from general surgical specialties. Heartening fact is that a third of these were from GI surgery. So by GI surgery, I do not mean departments of surgical gastroenterology. I mean that these trials were on GI surgical topics. But again, most of these are single-center trials, and very few of them are funded. Very few of them are multi-center collaborations. So where do we run into challenges? So we run into challenges at the methodological stage, in logistics, and then finally ethical concerns. So first, starting off with methodological constraints into doing studies. So first, I want to do a study, but where will I get the patient for my study from? So if you talk about, say, for example, if we take randomized trials, which is supposed to be the highest level of evidence, then in surgical trials, randomized trials could be put in three groups, broad groups. One, which look at drug usages in surgical patients. So you could have octreotide, POPF, no POPF, or you could have, say, NSAIDs causing POPF or no POPF, pain control, etc. These are drug trials, not significantly different from drug trials in the medical studies. The second is where I compare surgical intervention with non-surgical intervention. So I could compare resection with RFA for an HCC. I could compare a laparoscopic CBD exploration with an endoscopic treatment for CBD stones. So here is where the recruitment becomes a problem. So when you offer two very divergent treatments to a patient and explain equipoise to them, patients are in general more likely to prefer non-surgical treatments. So if I talk about my experience, my first real brush with research. So I've been interested in research from my school. We have had a little bit of research in our MBBS, but my first real brush with research was my MS dissertation. And this was my MS dissertation to compare single stage laparoscopic CBD exploration with a two-stage endoscopic followed by laparoscopic cholecystectomy. So I would sit down with the patient, spend half an hour, explain to them pros and cons and of everything. And then finally the patient would say, and these are mind you patients from very poor backgrounds, most of them are probably illiterate. They would say, thank you, Dr. Saab. Nobody till now has explained it so clearly to us. But I think we go with the endoscopic route. So they refuse consent. You spend half an hour, they refuse consent. Some of them consent. And then 3 days later, when you call them for getting admitted or for getting the ESCP done, they come back to you and say, so we had a second opinion, not from a doctor, but from my relative who told me to go ahead with this thing because it worked for him when it was done for him. So these are real life situations where we do not get consents from patient. Patient preferences play a very big role in terms of when we are doing randomized trials. Third category of studies is where you are comparing two different types of surgeries. So this could be something like you could compare dunking to a ductal mucosa, a pancreatico-jejunostomy to a pancreatico-gastrostomy. So here, generally, patients may not make much of a problem, but then there are but then there will be questions about who will operate. So while I was doing this study on CBD, my colleague had a study which compared laparoscopic with open inguinal hernia repairs. And then the patients would come and say, see, we came all the way for this particular senior consultant who's an expert on laparoscopic inguinal hernia repair. Why would we give you consent to do an open hernia repair on us? So again, even if you're comparing two surgical modalities, the person who's going to be doing it, what is the patient's preferences, all play a role into how are you going to get your patients recruited into your study. Even outside the purview of randomized trials, when you want to do studies, observational studies or cohort studies, A single tertiary care center which specializes in diseases may also not have volumes of a single disease. So diseases like cystic neoplasms, incidental carcinoma, gallbladder, these are not very common diseases, even zones where there is endemicity, and in tertiary care centers where you are likely to find patients being operated for these. So we understand surgical intervention is an irreversible act. And if you leave the surgical decision of whether you're going to do a surgery or not to chance, it's more likely that the patient recruitment is going to be a challenge. So next problem and this is again a problem that you face at all stages of surgical trials, is standardization. So there is lack of standardized techniques. So inter-surgeon variations are significant. Even for the same technique, no two PJs, no two surgeons do their PJs alike, no two people do their anastomosis alike. And then there are protocols, not just there is a pre-operative protocol which varies, there's slight nuances in the post-operative protocols, even within the same teams which vary. Next, variability in surgeon skills and techniques. So no two surgeons are going to operate the same way. In fact, it's a known fact that if you look at the shoulders repair, which gives the best results, but only within the shoulders institute and not outside of it. So most of the techniques have the best results in the hands of those who described it. And in fact, not only do we grow over periods of time, we are a different surgeon today than we were 5 years back, but even we are a different surgeon on each different day. So variability is immense. So this is a graph that shows that what happens in the surgical procedure is just one small part of it. There are many other factors that encompass and intersect with this. So you could have the surgeon, the team, the nursing team, the medical team, the anesthesia team, the operating theater, the pre-operative, post-operative care. So the variability in results is affected by so many factors other than the technique which is which is being studied. Next, when the way you capture data varies. If you look at retrospective studies, the way the data is being recorded, what data is being recorded, so at different points in time, you may not feel that this particular data is important to record and that data would be missing. Next, not only is our treatment varying, even no two patients are the same, no two diseases are the same. So there's a lot of heterogeneity in patient population and diseases. So when we do trials, we define our inclusion and exclusion criteria to ensure that we are not comparing apples and oranges. However, when we have overtly stringent criteria, in order to homogenize our study population, we are going to have difficulty in accrual. We are going to have longer durations of studies, greater resource utilization. Then sometimes the study may run into such a long duration that it may become redundant. What you are studying may no longer be actually of any relevance. Or B, even if it is of relevance, is it even generalizable? So this is the consort of my MCH thesis, which was on endoscopic versus surgical management of chronic pancreatitis. So I screened 260 odd patients and I included 50, 1/5 of these patients. So I remember Dr. Kapoor came for my exam, and so he, in the last part of the Viva, he said, so you got only 1/5 of your patients included. So even whatever be your results of your study, are they even generalizable? Are they even applicable if more than 4/5 of the patients do not fulfill these criteria? Next, we talk about standardization, differences in the techniques and protocol. But the most important aspect is when a new technique comes, we see a new technique, we read up about it, we see that it's got very good results, and we want to, really come back to our practice and apply it. But then are we ready to change what's been working for us? So my technique doesn't have the 98% result that this new technique is describing, but I've got an 85% result, which is reasonably good. How do I go about changing it to this without any guarantee that I will even get 80% with this technique? So again, I go back to my study. So it's not just difficult to change mindset of self, it's very difficult to change mindsets of peers and then your allied branches. So when I was doing the study, so my guide was the surgeon and my co-guide was the endoscopist, and they gave me this thesis, and I was supposed to go visit the ERCP room where patients would be getting dated, and I would be evaluating those patients and randomizing them. So I would go there, and then the SR would tell me, "आज कोई मरीज नहीं है, आज कोई मरीज नहीं है." Then I started confronting them with their diaries and saying, "कहाँ मरीज नहीं है?" And then they would be like, इसका ना पहले ईआरसीपी हो रखा है, ये पेशेंट कंसेंट नहीं देगा, ये पेशेंट ऐसा है. बिकॉज देन वन ऑफ द वेल विशर्स sat me down and said, see, you come here every day, we appreciate your enthusiasm, but see, these are our learning cases. We are going to learn ERCPs on these patients. What makes you think we want to lose out on our learning chances for the sake of these studies? So there are multiple levels of obstacles that you face when you start doing these studies. So, and after this, the study got completed, then the study got published. But even today, there's a lot of data after this that has been published that single stage explorations are better than two-stage ERCPs followed by laparoscopic cholecystectomies. But still, patients go for ERCPs first, followed by cholecystectomies. And these are not just because the patients are going to the endoscopist. A vast majority of surgeons also who have their hands full do not want to embark on a CBD exploration laparoscopically. They would rather do a cholecystectomy after an ERCP. So changing mindsets is something that is even more difficult than producing evidence. The next part of it is that when you're doing these trials, it's very difficult to blind surgeons and also difficult to blind patients in a lot of surgical trials. If you're going to compare surgery and endoscopy or non-surgical management, you cannot blind patients and you cannot blind surgeons. You could probably try blinding between open and lab procedures with sham dressings, but still it's very difficult. So at the end of all this, when you end up with small sample sizes, you have underpowered trials, which will be difficult to not just publish, but also difficult to draw conclusions or guide managements thereafter. So next problem is that, okay, I have decided I want to do the study. I've decided where I'm going to get my patients from, but when do I do it? So unlike drug trials, we don't have clear-cut phases of trials when it comes to surgical trials like phase 1, phase 2, phase 3. So if I start enrolling a patient into a randomized trial from my first patient, I'm going to have a learning curve. And that's going to mar the results of this new technique, which could actually be better than what is the standard technique. Sometimes, if I wait for stabilization to happen and my learning curve to cross, I may no longer be in a position of equipoise. I may be either convinced based on my personal experience that this is better or worse. So, something similar. So, in this thesis that I got was after a pilot study on 30 patients. But my first 6 patients who got randomized to the lab CBD arm, 5 got converted. And I was actually in a very big dilemma. What the hell am I doing? The other 5 patients who have been randomized to the ERCP arm have all just gone home with a nice cholecystectomy. And here are these patients lying with big wounds, wound infections, staying in hospital for 2 weeks, morbidity. Why am I doing this study? I really had doubts. Of course, not that I could do much as a resident, but I was grappling with that. But then things improved. Next 40 cases, there were no conversions. And then there were pancreatitis after ERCP. There was a perforation after ERCP and a mortality following ERCP pancreatitis. And that's when I began to see the equipoise again. And that's when I began to realize that for evidence to be generated, we need to have patience. So then also there is an ethical dilemma of subjecting a patient to a new procedure. So like I said, I may have 85% result, but if I use a new technique, I'm going to bring down that result a little bit, at least for my first few patients. So how do I justify that? How do I justify that to that particular patient whose outcomes are getting affected because of the new technique? And our ability to convey true equipoise to patients affects the way we are able to get consents from patients. Next, and the most important, are logistic challenges. So I want to do a study. I've decided how I'm going to get my patients. I've decided how I'm going to do the methodology, but I really don't have the time for it. So as surgeons, we're in a unique situation where we face competing demands on our time. So we have clinical care, we have operations, we have emergencies, we have our teaching responsibilities, and added to all this, we also have administrative responsibilities. So we feel that we lack time for structured research. Second are funding constraints. So research takes not just time, but also takes money. So you need to follow up patients. So most of research is resource intensive. So we have heard a lot about AI from the morning, about ICG, AI, robotic tech, laparoscopy. So technology needs money. We need gadgets. We need specialized facilities. If we want to do studies on basic sciences, we need to do heavy metals in urine, or we want to do genetic analysis, we need funds for this. So money is another constraint for doing studies. So technological barriers, so the high cost of these gadgets, non-availability, learning curves for using these gadgets again. When you use AI, do you have adequately annotated data sets to be employing them for generating models? Then there's lack of mentorship outside of institutes like this. The data that is being stored is of not very good quality. We have regulatory and ethical burdens as well. True equipoise is often very difficult in surgical trials. We are all human beings. We all have our slight bent towards a particular thing. True equipoise is often very difficult. And even if you have true equipoise, convincing everybody else on your team that there is a true equipoise is another mammoth undertaking. If we look at the acts of randomization, concealment, and blinding, and then look at the ethics and basic tenets of autonomy and non-maleficence, these are somewhere at conflict with each other. So finding a fine balance between the principles of clinical research and of clinical practice is very challenging. And finally, as surgeons, we are always taught to think on our toes. You need to take decisions. You will not always have all the information available to you, and somewhere you need to get what you have and take decisions. That's what defines a surgeon. But this aspect of surgical training that emphasizes decisiveness and action, whereas research requires uncertainty tolerance and hypothesis driven thinking, they are also perennially at conflict with each other. So what do we do? How do we overcome these challenges? So this is a paper that was published in JAMA in 2021. Study of over 12 years, they identified 388 trials that were published in high impact journals, 2 medical and 6 surgical journals. So what did they find? They found that the size of contemporary surgical trials was small. Most of the time, the outcome measure was minor clinical events. Trial registrations were suboptimal. Either protocols were not being published or there were discrepancies between publishing protocols and final published trials. Reporting biases were frequent. Few trials controlled for the surgeon experience or assess the quality of the interventions that were performed. So this basically told us that there is a lot of scope for improvement in the quality of surgical trials that were being conducted. So what do we do? So we need formal training in research methodology. So currently NMC makes it mandatory for both students as well as teachers in medical institutes to undergo training in research methodology. However, this is not a one-time thing. You need to keep revisiting it often. You need to incorporate structured research methods training into your residency programs and professional continuing medical education programs. You need to enroll into workshops on grant writing, data analysis, and scientific communications. Then you need to create multidisciplinary teams. So, one person cannot do everything. Whether it is a surgery or a research, one person cannot do everything. So you need to take on board biostatisticians or epidemiologists or data scientists, research coordinators. So they'll increase the scientific rigor of your study. This shares your workload, so there is less of your time constraint. They look into those parts where you're probably a better surgeon. You know what you're doing, but you probably may not understand research methodology as well. So they will bridge those gaps for you, and they facilitate complex analysis and accurate reporting. Next, addressing time constraints. So for people who are protected in institute setups, you could get protected research time. So you could dedicate one of your non-surgical day as an academic day dedicated to clinical work, or dedicate some part of your vacation time to your research work. Or you could have protected research blocks. You could have rotational research postings or academic sabbaticals you can take. However, if we move on to people who are working in the private sector or corporate sector, this is very difficult for them. There is absolutely no incentive for them to dedicate one day out of their working week to research. And so here it becomes very important to inculcate a culture of research so that the motivation comes from within. The second option available to those people is, if I don't have time, I should find somebody who has time. So I can give you data and somebody else you can collaborate with who can use this data to increase the size of their study and do the work. Then third, almost all setups today have some form of residents, trainees, or fellows who can be entrusted with this data keeping and studies. And the most DNB or MCH programs would anyway mandate a dissertation by these residents. Next, how do we go about timing our study in the timeline of an innovation or a new technique. So the ideal evaluation pathway, this provides us with a framework akin to your drug trials. So it gives you at each particular stage of development of a technique, how do you go about? So first is idea. So when you have a new idea, you have described a new technique. So you describe in what patient, and you describe the technique in great detail as well as the outcome. The next is the development step. When you do it in consecutive patients, refine the technique, cross the learning curve, improve your outcomes. Third is the exploration stage, and this is the stage at which a pilot randomized study can be done, or you could do a larger cohort study to understand what are the complications and whether this is and how to deliver this new technique. The fourth is the assessment stage at which proper randomized trials can be planned. And fifth are long-term studies, which is similar to your post-marketing surveillance, where you can get involved you get the real ground reality of how this technique is working on the ground in multi-center trials. Then how do we address accrual issues? So where we are having a big problem with patient consent. So there's something called as a comprehensive cohort design, where you conduct parallel preference arms. So patients who have refused consent, you continue to follow up those patients who have chosen a particular treatment and use that data also, because this then addresses concerns about generalizability, because now you know what's happening to patients who had chosen a particular treatment out of preference. Second is, we live in a country where ultimately, if you put together your data, almost all diseases you will get in huge volumes. So this facilitates development of registries. We can use alternative study designs. So large non-randomized observational studies, propensity matched comparative studies, or building national wide registries for diseases. In fact, honest long-term observational studies may give you better data than poorly conducted randomized trials. So for this, however, we need to have a very good prospectively maintained database that captures everything. So in this context, SGPGI probably was one of the first hospitals to spearhead the hospital information system. However, clinical data still doesn't get captured very readily into your hospital information systems, and you need to sometimes put systems into place to capture this clinical profile of patients. So you could either keep your own database, you could have digital registries, you need to have documentation templates and operative note templates and follow-up systems. So if we look at this particular study, this is published way back in American Journal of Surgery, way back in 1995, the Marcucci criteria. So this was a retrospective study. And the result of the study, these criteria that were described for the first time in this study are as relevant today, 30 years down the line, and used by almost everybody who is planning hepatic resections on cirrhotic patients. So this tells us that it is not just the randomized trials. Sometimes it is very good observational studies that are important. Another study, which was quoted by Kapoor sir in the morning. So if we look at this study, this is a very prime example of how we identified a problem that was very indigenous to us. So an area which is endemic for gallstones, as also for gallbladder cancer. You get a lot of patients with thick-walled gallbladders. How do you treat them? A lot of them will eventually turn out not to have carcinoma gallbladder. So doing extended cholecystectomies would probably be an over-treatment. So this is the anticipatory extended cholecystectomy, which was which was first described. It's a small study published about a decade back, but today hardly any discussion on thick wall gallbladder would be complete without its mention, and most of us use it in our day-to-day practice as well. Next, we need to standardize interventions. How do we? Okay. So how we have to standardize interventions. So video assessments, skill benchmarks, and publishing protocols is one of the ways to go forward. Funding mechanisms are in place. So institutes have intramural grants like SGPGI, AIMS have intramural grants, but there are others like ICMR, DVD, DST, which are willing to provide funds. If you do not have funds, like time, collaborate with those who have funds. Collaborations often yield better grants and also result in better visibility for your research. Surgical gastroenterology is a fertile area for research opportunities, many abound. This is just a small, very little representation of the number of studies which have been done in the area of gallbladder in SGPGI, just to look at how we have identified our own problems and then gone on to delve deep into it and provide solutions and data on it. Everybody in their own capacity can contribute to research. So private sector, one can look at how to make surgery more affordable, treatment more affordable. How do we put ERAS programs into place? At the end of the day, we are all working towards delivering surgical care safely and at scale across heterogeneous groups. Finally, no data is small. Even case reports contribute tremendously. Sometimes when you are stuck up with a very difficult case, it is these case reports that give you bailout measures. In fact, the description of DNA was first published as a letter to the editor. And to conclude, I would say that we all need to identify clinical problems and seek solutions. No one can do it alone. You need to collaborate, find like-minded people. Funds, like Madam said in the morning, alumni associations can help for you to collaborate as well as get funds. You need to either find time yourself or people who have time. And we need to publish everything, like Dr. Ibrar has said, no data is big or small. To conclude, every GI surgeon in this hall is already doing research. The problem is we are not capturing it, not analyzing it, and not sharing it. Thank you.
Thank you, Dr. Ravi. Very excellent and comprehensive review. I think we can take the comments and discussions and here. I think from permission of the organizers because of dearth of time. So maybe we can have that comment at the end of the session.
He is going actually, that's why I wanted to.
Thank you, Dr. Anu. This was a surprise. We did discuss that I would want to present something, and then I thought, what should I present? And maybe in my so far surgical career in liver, there are 4 papers which are very near and dear to me because these are the new techniques. There are 3 new techniques that I have described, and this is one paper. And then it doesn't look nice that you want to present all your thing. The idea is not to showcase. So I just said there is a very peculiar aspect with this paper, and with that you give this. The topic, it says long gestation publication. So this is the last presentation and only 6-7 of us are here. I would just quickly, so I would just say the concept of what this paper is. This is the anatomy paper. Problem and advantage of anatomy is, problem is after describing the entire anatomy, somebody might say, so what? Because anatomy is always there. The other thing is, if somebody likes the anatomy, or if you do find the advantage of anatomy, then it can become a very, very basic, very, very important landmark, which theoretically can have a lot of implications. So I would present what my thought was and what came out of it. It's a very simple concept. Before I start, why this long gestation? So what happened is, I'll just give a 1-minute summary. I entered into liver transplantation almost 19 years ago. And then when I entered the unit that day, 197th transplant was being done. And I remember that figure because I wanted to remember that figure. And then from SCPGI, from GI surgery, you go and then you realize that you've been taught or you study that there is a celiac artery which divides into left gastric, it divides into common hepatic, and there is a splenic artery. The CHA goes and gives a left artery, and then it's a right artery, it divides into anterior and posterior. This is what most of us know. This is what is the concept of normal anatomy. In the initial 1 or 2 or 3 months, whatever transplant I saw, this anatomy was barely seen in only half the patients. In fact, not even half the patients. So we were just sitting together one day, and then suddenly I said, sir, the anatomy which we have all read is hardly seen. So then he said, why don't you look at anatomy? So he says, look at anatomy, take it as your fellowship project, and publish this paper. Maybe we'll do 300. So by 300, you publish this paper. So that was, so I was allotted this paper at maybe 200, 210, and I was supposed to write the anatomy at 300. That thing went on, and then before anatomy, the basic concept, the reason why I wanted to write this paper was, whenever we go to the conferences, there is a presentation, somebody would say, this is the anatomy, very rare, you would reject the donor, what would you do with this donor? So the idea was, I thought that there are patients, there are donors which are surgically non-doable. So there should be a donor classification of anatomy, rather than I coming up with one idea, somebody else coming up with another anatomy, and which is non-doable. So there should be, the donor should be classified. So the basic starting point of this paper was that there are 3 types of donors. Donors with so-called normal anatomy, which need minimal or no modification and can be done in a usual way.
donors who will require modification, but can be done with expected problems. So somebody with, so either you need changes in the donor in the graft or on the bench, but they are doable. And then there are anatomy, which are really very tricky anatomy. You should not be doing it. Even if you do it, there can be a problem. So that donor classification, I had to write at 300, and then obviously it's not such a long thing, but then some laziness, and then you got busy, and then slowly the data built up. Finally, in one line, the study got published at 3,035 donors, and this is after 17 years. So a little story about this is what. So I was supposed to write this paper at 300 donors, and then went on to write this paper at 3,035 donors. What happened on the way was that classification became only a part of the study. So 3 types of donors with normal doable anatomy, normal risk, high risk, and non-doable anatomy became in the last part of it. And then we ended up describing the anatomy. And when we were doing it, what we realized is why this study was done. Most of the anatomy, there are a lot of anatomy papers in the literature. Many of them are DDLT anatomies. So they would describe how the celiac trunk would divide, how the splenic artery, LGA. Nothing is for LDLT, because in LDLT, it's not important from where the arteries are coming, from where the bile ducts are coming, because DDLT, you have one duct, DDLT, you have one big artery. LDLT, important thing is not where the artery is coming from. That's also important. Important thing is there one artery in the graft? Is there 2 arteries? Is there 3 arteries? Should you be doing it? Is there 1 duct, 2 duct, or 3 duct? So this is what was the basic premise. So with this premise, we the usual all the data of 3,035 anatomies is on radiology and correlated with anatomy. So as we all do, all the donor dissection diagrams are drawn manually on the operation note, and it is compared with the radiology. And then we took all these things, and then we gave a new classification for right hepatic artery, for left hepatic artery. The portal vein classification, we did not give new because the variations were as reported in literature. And there is a new classification for right and left hepatic duct. The classification is based on a very simple concept. For a right hepatic artery, we will write it as RA. For a left hepatic artery, we'll write it as LA. 1, 2, 3 means there is 1 artery, 2 artery, or 3 arteries. Similarly, for left hepatic artery, if there is 1 artery, it is LA1. If there are 2 arteries, it is LA2. If there are 3 arteries, it is LA3. Now, the other point is where these arteries are coming from. So right artery, if it is coming from CHA, which is usually case, it is C. If it is coming from SMA, it is S. So RA1 would be either RA1C or RA1S. This part is easy to learn. Then the variations are difficult. The aim is not to learn all the variations. They can be kept in your place. The idea is, suppose we have 2 arteries on the right side. They can be RA2CC, they can be RA2CS. Similarly, 3 arteries, same thing on the left side. So initially it looks like a mathematical formula and looks a little different, but look at the concept. What happens is you are going to the OT, there is a call from the resident or there is a call from a consultant. We are operating, वो left वहां से आ रहा है, right goes there, वो वहां है. He gives you so the artery will become like a code. So in today's word AI thing, so the reporting would be RA2CC, LA2CL. So now you know that there are 2 arteries on right side coming from such and such, left artery coming from such and such. So that's the basic concept of right and left artery. And then on, there are variations of all these. You need not remember. Actually, all these anatomies are real anatomies. All these diagrams are real patients. All the first picture you see, this is RA1C. So that means only 1 artery, which is coming from CHA. And then the differentiation is what is happening on the left side. So on the first picture or second picture, all these pictures in the initial, all these parts, all these pictures, there is only 1 right artery, which is coming from CHA. So it is RA1C. But then on the left side, is there 1 artery or is there 2 arteries, or there are various variations. So I would not confuse discussing, we would just discuss the concept. So the idea of this, so all these are real data of 1 artery and then various variations, RA1, RA2, similarly 2 arteries, similarly 3 arteries. The important point to mention here is this is all based on the commonest anatomy, commonest first. So as we see, important point here is, we can discuss a lot, but I would skip all those. If you look at the right lobe, 95% of the right lobe will have single artery. Double arteries are present only in 5% cases. 3 arteries are very, very rare, but you do find them, 0.19%. So what I'm saying is, if we, even without looking at CT scan, chances of getting a single artery on right side is 95%. The multiple arteries on right side probably does not happen or happen less than 5%. Then there are various, this is common or other things, those are all discussions. Similarly, for left hepatic artery, the left hepatic artery can come from CHA, it can come from LGA, or it can come from SMA. And similarly, the same classification, multiple types of arteries. The difference here is, if you look at the left hepatic artery, single artery in left lobe is only 60%. So left lobe, if somebody is harvesting, 40% chance that there will be multiple arteries. So even without looking at which is commonest and what are, and each picture has a significance. Somebody says, this is the picture, I know where the problem would be, which artery is likely to get injured, where you should preserve, where you should cut, how would you harvest the graft. So just by this code, so important take home point, apart from so many other things, on an artery is, on right side, 95% arteries would be single, but on left side, 40% of the arteries would be multiple. Similarly, the same classification for bile duct. Right, RB1, RB2, RB3, RB4. There cannot be RB5 because there are 4 segments on the right lobe, so there can be only 4 ducts on the right side. Similarly, left, there can be only 2 ducts. So this is what we have seen, and these are all real pictures. So if you look at it, this is the commonest anatomy, single left, single right, 62% cases. These are all situations where you would see multiple 2 ducts on the right side. We have divided it into a pattern from below upwards. The reason is, if we cut the right lobe, we'll cut it from here to here. We'll cut it from below to upwards. You want to do ERCP, ERCP would be done from below upwards. So first duct, is it anterior or posterior? Is it posterior or anterior? So all these things. So there are 2 ducts. It is present in 35% cases. 3 ducts are rare, but possible. 4 duct we have seen only in 2 cases. So 4 duct also, it exists in donors. But then on the right side, compared to anatomy, the 95% right lobe will have single artery, but 40% or 45% there would be multiple ducts on the right side. If you look at the left lobe situation is different. I said 40% of the left lobe will have multiple arteries, but duct would be single in left in 99% cases. So 2 ducts on the left side. I mean, these are very, very basic things that I'm presenting as a concept. Each and every anatomy can be discussed. I'm sure what will happen is, once the idea of giving these anatomy is to, one, you can make it as a code. If people do accept it as anatomical classification, the radiology need not write the entire detail, this artery coming and crossing over this one. They just have to put in a code, RB1, LA2, CS, bile duct, and one code will become the entire anatomy, which everybody would follow if people want to follow. If not, then these things are important, because once you do a left lobe and then you know these are the variations possible. We have burned our fingers. There are places where this artery was not seen, not described, and then we got the injury. So a lot of discussion can happen on all these things. Portal vein remained the previous classification, so I did not classify the portal vein. And then the final part of the classification. So instead of saying doable anatomy, rare anatomy, we made it into 3 class of donors: class 1 donor, class 2 donors, and class 3 donors. Class 1 donors are doable without any major modifications with the usual risk. So all RA1, LA1, RP1, so single bile duct, single artery, they will become class 1 donors. Double ducts will become class 2 donors. They are doable with acceptable risk. And 3 ducts, all these things theoretically can be done, but then it will become very risky. Although as a surgeon, most of the surgeons would say that I would handle whatever it comes. So, but this is a classification, and I just wanted, these are all real pictures of non-doable donors. I would just give an example in the want of time and not go on. These are all real pictures of our patients we had, and this is what. So the concept was of right lobe or left lobe, which artery you get, how many numbers, where they're coming from, so that you know how to harvest, you know how to modify, you have to reconstruct what needs to be done. And this is a concept. If it is accepted, fine. Otherwise, this is what we did. Only thing is, we took many years putting this paper in. Okay, thank you.
Thank you so much, sir, for this insightful talk. With this, we close this session.
सर आपको नहीं मारा Yes, please come. सर आप कुछ कहना चाहते हैं? नहीं, Thank you, sir, and my personal thank you to Dr. Anu and the organizing team. Really, it's been a very nostalgic and memorable event. I must congratulate and I would say teacher of teachers and speaking before them is a big opportunity and a great honor. Thank you all so much.